We are live now. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, episode 24 of Amogs Emergency Obstetrics Committee with Uttarakhand OBGYN Societies. So it's my privilege to introduce the convener of today's webinar, Dr. Sarveshwari Nautiyal ma'am. Ma'am is the founder and managing director of Kishori Foundation, and ma'am has previously worked as a director, Medical and Health Services, Government of UP. I welcome you, ma'am. It's my privilege to introduce the coordinator of today's webinar, Dr. Radhika Ratori, ma'am. Ma'am is the past secretary of Dehradun OBGY Society. I welcome you, ma'am, and I hand over the session to you.
Thank you. A very good evening and a warm welcome to all the seniors and all the delegates and the faculty members for this webinar, which has been organized by the Amogs Emergency Ops Committee in association with the Uttarakhand committees. And I give my warm respect to all the Amogs office bearers, Dr. Kiran sir, Dr. Bipin Pandit sir, Dr. Rajendra Pradesi sir, Dr. Madhuri ma'am, and our dear Sneha ma'am. I would like to introduce our very dynamic Sneha Bihar ma'am. Ma'am has always been a guiding source and an inspiration to me, and I joined the breast committee under her able wings. And ma'am, thank you so much for giving Uttarakhand this opportunity to be with you and to join hands with you for such a noble cause. May we please have Sneha ma'am's CV, please?
I think we go ahead with God's blessings first. Let us have the prayer first.
Yes, ma'am.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं
Unmute yourself. I would hand over the session to Sneha ma'am, please, to introduce our dynamic chief guest and guest of honor, please. Sneha ma'am.
Yes, thank you so much, Dr. Radhika, for that wonderful coordination you have done for me. And of course, a very good evening to all of you. My respect and regards to respected Dr. P.K. Shah sir, the past president of FOXY, Dr. Sunita Tandurwadkar, the president-elect of FOXY, who are the chief guest for today's program, and my dear friend, Dr. Charmila Yahu, the vice president of FOXY, who is the guest of honor. I also welcome the illustrious speakers for today's program, Dr. Geeta Balsarkar, who will be speaking on vacuum extraction, and Dr. Parikshit Chang, justifying his role in forceps, even in modern obstetrics. Respected seniors from Uttarakhand, Madam Sarveshwari Nautiyal, the senior most person who is conveying this program, and of course, Dr. Jyoti Sharma, Madam, Dr. Vinita Gupta, and my dear friends, Dr. Aarti Luthra, and past president, who is the past president of Uttarakhand, and Dr. Minuvesh, the current president of Uttarakhand, as chairpersons. Our esteemed panelists, Dr. Anudhir, Suman Sethi, Swati Agrawal, Priyanka Singh, Pallavi Singh, Achal Agrawal, Rajalakshmi Mundra, and of course, the dear friend Dr. Archana Singh, the Secretary of Uttarakhand, our loving and caring, sweet coordinator, Dr. Radhika. A very good evening and warm welcome to all of you on behalf of Team Amogs, Dr. Kiran Kurtakoti as President, Dr. Bipin Pandit as Secretary, Dr. Madhuri Mehndra as Treasurer, and of course, immediate past President, Dr. Rajendra Singh Pardesi, and the National Coordinator of Amogs, Dr. Parag Biniwale. As obstetrician, our aim is to deliver healthy baby from a healthy mother, and of course, with respectful maternity care, and make sure that it is an emotionally fulfilling experience for the mother. And that is why the topic selected today, which will focus not only to reduce the maternal mortality morbidity, but also the perinatal mortality and morbidity, because the panel discussion which I'm going to moderate will focus on the near miss cases, which actually, the woman who have otherwise died had it not been the luck and the good care on her side. So definitely the pregnant woman or one who has recently delivered, we have included very interesting cases. And with such excellent speakers and the panelists, I'm sure this is going to be very beneficial to all the attendees. So friends, just to make you aware that, as breast committee chairperson in my tenure as 3.5 years almost, we have done 300 programs all over India, maybe educational awareness and even lots and lots of publications and research as well. As Amogs Medical Disorders Committee chairperson, last year, I'm sure Pardeshi sir is here, 75 plus programs were done under my chairmanship. And of course, this is the 24th episode of Emergency Obstetrics Committee. I just request all of your attention that I urge your wholehearted support and blessings for my candidature for Foxy Vice President from West Zone. And I hope I can do justice with whatever endeavor I'm going to go ahead. Thank you so much. And over to you, Dr. Radhika. If you can project the CV slide of Dr. P.K. Shah, sir, please. Yeah. So, very good evening to you, sir. All of you know, sir, very much. I'm not going to read all the CV. Sir is the past president of Foxy, IAG, and of course, dean of the, the ultrasound. He's the dean of so many.
Dr. Sneha, he is recently the trustee of Mumbai Obstetric Gynec Society.
Yes, so we are
Sir, you need to add that.
Yeah, I think I should add. Thank you.
Yeah, you're a trustee of the Mumbai Obstetric Gynec Society.
Okay.
And we are privileged to have you, sir, and your blessings.
Thank you very much.
Thank you, sir.
Yeah.
Over to you, sir.
So, good evening, everyone. And it's nice to be a part of this Amogs Emergency Obstetric Committee with Uttarakhand societies. I thank all the office bearers of Amogs, Dr. Kiran, Dr. Bipin Pandit, Dr. Rajendra Singh Pardesi, Dr. Madhuri Mendale, and obviously Dr. Sneha Buher, who is the chairperson of this Emergency Obstetric Committee of Amogs. And looking at the way she works, I have seen her working continuously for the last few years. And it is amazing that a person can have so much energy to do so many academic activities. I'm really surprised that how you manage this. Anyhow, all the very best for your vice president's post and success for the same for the election coming up in 2024. I also would like to thank today's convener, Dr. Sarveshwari Nautiyal, whom we met 13 days back at Dehradun, along with so many other people.
Thank you
to be with us today. Hi, ma'am. It's so nice to share this particular platform with none other than Dr. Sunita Tandurwadkar, who is the president-elect of Foxy, and Brain with Beauty from South, Dr. Charmila, who is a guest of honor. Now, when it comes to speakers, let me tell you, I know both Geeta and Parikshit so very well that when I was a president, I had to decide whom to take as my secretary, joint secretary. Ultimately, I decided to go for Parikshit, but both are equally close to me, and I really like them for the amount of knowledge they have and the way they teach all the rest of the people in India. What is good is that the topics that are selected are very, very close to my heart. Operative vaginal delivery. In my unit at Sion Hospital and even at KEM Hospital, we used to have on an average 8% vaginal operative deliveries. Now a situation has come that the residents don't see forceps application. Vacuum, yes, once in a while, but forceps application has gone down tremendously in majority of the teaching institutions. And I hope the seniors take this message very seriously and teach their juniors about operative vaginal delivery. So Geeta is going to speak on use of vacuum in today's obstetric practice, and Dr. Parikshit will be talking on forceps in modern obstetrics. Very important topics. And then the panel discussion on near miss cases, which are going to be managed by Dr. Sneha Buyar with a very distinguished list of panelists. But I would like to say that the chairpersons whom you have selected, I know many of them, including Dr. Meenu Vaish, Dr. Vinita Gupta, Dr. Jyoti Sharma, Dr. Aarti Luthra, Dr. Anu Dheer, Dr. Suman Sethi. All these people, I think we met during 3 days of our stay at Dehradun. And the coordinator, Radhika, all the very best, do good, and learn from the seniors how to get into Foxy. Okay, all the best to all of you. And thank you very much for making me a part of this webinar. And I wish Sneha all the very best for all her future endeavors. Thank you very much.
Thank you, sir. Thank you, sir. Thank you so much. You have been always so appreciating and so encouraging. I mean, we really are very thankful to you, sir. And I have always been very fortunate to have you as mentor in all my throughout my journey in Fox.
My pleasure.
Thank you so much, sir. Sir, thank you, sir. So we welcome Dr. Sunita Tandurwadkar, madam, who is the Foxy president-elect. I have just, madam, we have missed you though initially. We are very eager to listen to your precious words. All of you know, madam is such an illustrious personality.
Hello, Sneha, no introduction.
Yes, yes.
We all know each other, we all love each other.
Yes,
And
ma'am.
first of all, Dr. P.K. Shah, sir, namaste, namaste,
Namaste,
namaste. Dr. Pardeshi, sir, so nice to see you all. When Sneha gives me a call, everyone knows I don't have a word no for Sneha, though I'm tired of joining as a chief guest in every webinar because दिन में 3 बार तो भी होता रहता है. Nevertheless, it's such a pleasure, though I say I'm tired, but when I join, I love it. Because sitting in my comfort zone, I meet my great friends. And when you say it is with Uttarakhand, I can see my dancing Sarveshwari. I think, Sneha, you only introduced me to Sarveshwari 2 years ago, and I think she is closest to me than you.
That I don't
Dr. Meenu Vaish, lovely to see you, Radhika, and your boss, Aarti Luthra,
Hi, ma'am.
my sweet, sweetheart. Geeta is also joined here, and the vibrant Vice President of Foxy 2024, Dr. Charmila is here. So this is a beauty of joining. I know, Sneha, you are going through elections, and I don't mind saying openly to all, please love Sneha, support her, vote for her. And it's only not your vote, your entire society and your state all matters. Mobilize maximum people and please support Sneha, because I know Sneha wants to be in Foxy, but Foxy also need people like Sneha who just don't do the election for the sake of it or for occupying the chair. They do it because they wish to work in the organization. So organization need definitely people like Sneha. I know she will be a great asset to Bhaskar Pal, and she will also enjoy, though I missed working with Sneha, but she will be working with me. So I wish you all the best, and I think I have sent the hidden message also with whom she is going to work. So that should be sufficient. And me and Dr. P.K. Shah love one more girl called Sejal Naik. She's my daughter. So I know Sneha is supporting her. Dr. Pardeshi sir is supporting her. But I also humbly appeal you to support. She is a beautiful girl. But nevertheless, this topic today is the Amogs and Uttarakhand. And both the states are doing so good. Rajendra Dr. Pardeshi sir, we so difficult task, but you did it so beautifully, involving everyone. And now Kiran is juggling to reach to that stage where you and Nandita have taken Amogs, and I'm sure, I'm very confident also that Kiran will also take Amogs to another level. So we are proud of our city, we are proud of our state, and we are proud of our country. And dear all, please be active during my Foxy presidential year. I request you all to participate in all my social activities. I'm going to do those as many as possible. Thank you so much for making me a part, Sneha. Thank you.
Thank you so much, madam. We never want to miss you. We're so happy to have you and have your precious words as well. Thank you, madam.
Thank you. Thank you.
So it's time to hear from my dear friend, Dr. Charmila Ayavo, with whom we have been working since so many years. Such a lovely person, Vice President of Foxy, and of course, long list of posts and achievements. But I don't want to read it. Everybody knows Charmila as a charming lady who is a very illustrious academician. So over to you, Charmila, for your precious words here.
Thank you, Sneha. Thank you so much. My respects to Dr. P.K. Shah sir, Dr. Pardeshi sir, Dr. Sunita ma'am, and I'm seeing Dr. Geeta there, a great friend always. And Uttarakhand Society, you rocked the conference 2 weeks back. And I'm happy to see Sarveshwari madam, who was so enthusiastic, and the conference went on every minute was so precious, and we all enjoyed it so much. I'd like to thank Dr. Meenu Vaish, who also coordinated for the conference, Dr. Aarti, who chaired a session along with me. We gossiped for a long time there. And Radhika was sweet as always, did so well in her program, and we enjoyed the entire show. And it's an honor to be with Amogs along with Uttarakhand societies. And as Sunita madam said, Sneha is the person who definitely needs to be in Foxy, because as ma'am said, it is not like she wants a post. Foxy also needs her because she's such a hard worker, and everybody was astonished that she couldn't go through, and we were expecting her to be topping everything. But this time it will go through with flying colors, and we are all there with you, Sneha. Thank you so much for inviting me here. Thank you to all of you. Thank you so much.
Thank you so much, dear. And once again, I would like to thank Dr. Meenu and Dr. Archana for having, having this collaboration. Before I end, I invite my mentor and immediate past president of immediate past president of Amogs, Dr. Rajendra Singh Pardesi, whom all of you know. So over to you, Dr. Rajendra Singh Pardesi, sir, for your words.
Good evening, everybody.
Good evening.
Sir, my biodata, I wish to tell you my biodata because she has not read the biodata. My biodata finishes with the word, I am disciple of Dr. P.K. Shah, sir. I think this is my biodata.
So that is why you told me last time not to read. So
yes. So respected Chief Guest Dr. P.K. Shah, sir, who is my mentor since 1987 when I was in Sion Hospital. Dr. Sunita Tandurkar, our President-elect and Iron Lady. Today's guest of honor, Dr. Charmila, and our President of Amogs, Dr. Kiran Kurtakoti, and Convener, Dr. Sarveshwari Natyal, Madam. Dr. Parikshit Tang, Dr. Geeta Balsarkar. So I wish to congratulate Dr. Sneha Boyar for organizing this webinar with Uttarakhand. Because with the able leadership of Dr. Kiran Kurtakoti, now Sneha Boyar reached up to Uttarakhand also. It's a Devbhumi. So Dr. Sneha, you should take the blessings of Devbhumi. I think you will get definitely success over there. So this vacuum and forceps, these topics are very important to reduce maternal mortality, to reduce cesarean section rate, and they are very important. Dr. P.K. Shah sir taught us forceps and vacuum, but he was always telling you should give this option to mothers. And I am proudly told because it's an art of training and teaching. He used to assist us vacuum and forceps. And this is, I think, we are lacking in teaching our residents nowadays. That is not the residents' fault. It's our fault, seniors. We have to teach them. So under the able of leadership of Dr. Sarveshwari Natyal, Dr. Meenu West, and ever smiling Dr. Radhika Raturi, Dr. Aarti Luthra, I think this webinar will be successful. We cannot forget the warm hospitality of Dehradun and Uttarakhand societies in this FFD Con 2024 conference just 15 days back. We observed seniors like Dr. Sarveshwari Natyal, Dr. Meenu West, Dr. Aarti Luthra, and they were always in that conference. And we appreciate especially Dr. Radhika Raturi's efforts on administration of the dais, and which is really a difficult and tedious job. People are appointing all event managers and all that. But see, we have to appreciate the work done. And not only for one, but always in the morning and evening. We observed her. So congratulations, Dr. Radhika. Keep it on.
Thank you, sir.
So with this, see, webinar with Uttarakhand Society, we consider this as blessing from Devbhumi. So I wish again Dr. Sneha Boyar for her future endeavor in FOXI, for her Vice President FOXI election. Wishing every success to this webinar. Thank you. Thank you so much for inviting me. Thank you.
Thank you, sir. And of course, I'm sure all of you have experienced the warm hospitality, which I have experienced almost 2-3 times prior. And we have done the Ganga Aarti also on priority. We have already received the blessings of God and the warm hospitality by everybody. The warm felicitation, the royal felicitation of me and Dr. Sunita Tandurwadkar as at Dehradun was a memorable event for all of us. So with this, I thank all the respected dignitaries and of course the esteemed speakers and all the panelists and chairperson for gracing the program. And I conclude that the inauguration is over, and let us quickly move on to the academic session. Over to you, Dr. Radhika, for the further proceedings. Thank you.
Yeah, before you start that, we
Yes.
must thank Ritu for arranging this program, because
Yes.
though she is the chairperson of a committee,
Right.
she arranged this academic event not in Varanasi but at Dehradun. That is something
Very difficult.
absolutely difficult, but the local people helped her like anything,
Yes.
and they made it a great success. So we must thank Ritu also for this particular program.
I just thank Dr. P.K. Shah, sir. Sir, I would like to be your student again. Thank you, Sunita.
My goodness.
You have done a lot. I know you will do a lot. And thank you, Rajin Pradeshi, sir. And where is our Chami? And I can say I call her Chami because she's very beautiful, very sweet. And I thank for the words which you all have said for Sneha. And we know that all blessings from you all will really help us. And I think whole Uttarakhand is with Sneha. So hope for the best. And it's blessing, like Rajan Singh Pradeshi said, blessings from Devbhumi Uttarakhand to Sneha. Thank you, sir.
Thank you, madam.
I would like to say a few.
Yes, Dr. Meenu. Please unmute yourself. In
I
fact,
would like to add few words of Dr.
in fact,
Sarveshwari.
Meenu, you were supposed to give the welcome from your society, but maybe.
So good to see all the dignitaries, Dr. P.K. Shah sir, Dr. Rajan sir, Dr. Sneha, Dr. Sarveshwari ma'am, and all those of you who made this conference FDC Con successful. So thank you very much for joining us. And in that way, we have a good coordination and we have a good learning and good networking with all of senior persons, senior teachers and senior Dr. P.K. Shah gave a very good lecture on ovarian mass. That was very wonderful. We learned a lot. And I cannot forget Dr. Rajan. Dr. Rajan talked about the cesarean section, and that was very, very important message he gave to us, that how can the government is saying reduce the rate, and how can we, and maternal mortality, fetal mortality, all these factors are also important. And Dr. Sneha has taken very good topic today we can reduce the maternal mortality and fetal mortality rate by introducing tools and forceps delivery in our system in medical college, because sometimes they save our skin. And I will not stop here. I like to talk about Dr. Sneha. Dr. Sneha is a very grounded, very humble, and very good friend of all of us. So we wish a great success in her every endeavor she is doing. She's a very hardworking person. And all the best, Dr. Sneha. We all are with you, dear.
Thank you, my dear. Thank you so much. Thank you so much.
And again, love to Radhika. She is a wonderful person and standing by all of us. And Dr. Aarti, Dr. Sarveshri ma'am, all are together to join hands to have you food support from Uttarakhand.
Thank you, my dear. Thank you so much. Love you all.
Love you.
Gratitude from Uttarakhand societies to all the respected Foxy seniors for being so kind, and it was a privilege to host all of you over here. And thank you to Ritu ma'am for giving us this opportunity. And I must say that Uttarakhand has the most warm seniors, and the warmth that I have received is what I'm giving back. And each one of you have been so kind. We'll move ahead with our first session. We are privileged to have Dr. Geeta Balaskar ma'am as the first speaker today. And we have two exceptional dynamic chairpersons today, one being Dr. Vinita Gupta. And I will never fail to say I am here because of her. She was my external examination in post-graduation. So I can't forget her. And thank you, ma'am, for always being there a call away. Ma'am is the head of department at SGRR Medical College and an excellent academic person. She has many publications to her, and one person who I can literally say is a call away. She's always there to help all the juniors and always for referrals. Thank you, ma'am. And it is a privilege to have you with us as a chairperson. Our sweetest, dynamic Uttarakhand Society's president, Dr. Meenu Vaish, ma'am, the ever encouraging. I fall short of words to say thank you to her for always being a call away, always organizing things. Ma'am, it's a privilege to be under your wings and to have you always with us, taking our back. We welcome Meenu Vaish, ma'am. And I would please request Meenu ma'am to introduce Geeta ma'am, please.
Love you, dear Radhika. Thank you for the kind words. Now we are going to start our session. Our first session is on the place of the vacuum extraction in today's practice. The speaker is none other than Dr. Geeta Balsarkar. Dr. Geeta Balsarkar has a lot of feathers in her cap. So she is the editor-in-chief of Journal of the Obstetrics and Gynecology of India, 2021 to 2023. She's
Madam, sorry, I am just past editor-in-chief. I just finished in January. So I don't know how this has come up here. Anyway, no problem. I'm the editor emeritus now.
About your editorial in www.jogu.com, I was reading that. Yeah. So good to know you, Dr. Geeta. You are the past president Association of Medical Women. And you
are... the Dehradun Society is getting the journals.
Yes, ma'am.
Jogi.
We all are.
Yes. Yes, yes. Dr. Madhuri Patel is the present editor-in-chief. I am the just past editor. I'm editor emeritus now. I can start the talk if you can allow me screen sharing.
Yes.
Yeah. Radhika, I am Dr. Balsarkar.
Balsarkar. My apologies, ma'am.
Yeah, no problem. That it's difficult to pronounce. Yeah. So my topic today is on vacuum extraction. I can see about 19 or 20 faculty here, but I hope that more and more postgraduate students join here, because when Dr. Sneha asked me to talk on vacuum, I said, Sneha, I don't even have slides. Why are you making me talk on vacuum? Can I talk on something better? She said, no, you have to talk on vacuum. So that made me go back and read it. And I tell you, I really enjoyed going back. And I wish we train more and more postgraduate students on vacuum extraction. Really today, that is the need of the hour. The government wants to reduce the cesarean section, and it wants to bring down the maternal morbidity and the neonatal mortality as well. So there is no other choice than to go for the instrumental vaginal delivery. What is the vacuum? Vacuum is an instrumental device designed to assist the delivery by applying traction to a suction cup attached to the fetal scalp. Any condition which is threatening to the mother or the fetus and which is likely to be relieved by delivery. If the patient is fully dilated or near fully dilated, then vacuum really helps in early delivery of the baby. But one of the requirement is fetus should be at least 34 weeks. We cannot apply vacuum in a preterm baby. So if you come to the historical background, in 1705, Young described an attempted vaginal delivery using a cupping glass. This is how the idea of applying vacuum came from the 17th century. He applied a cupping glass on the baby's head and tried to apply vacuum at the other end. In 1848, Simpson devised a bell-shaped device, and it was called the air tractor vacuum extractor. In 1953, it was Malmstrom who developed a metal cup extractor, and we all know what is Malmstrom's cup. So it became synonymous. Vacuum cups became synonymous with Malmstrom's cup. But soon later, Silastic came in, and we are having very good Silastic cup of different sizes today, which really helps the vacuum delivery. So what are the indications for vacuum assisted vaginal delivery? Whenever there is prolonged second stage of labor, like in nulliparous women, is defined as lack of progress for 3 hours with regional anesthesia or epidural, or 2 hours without any anesthesia. If the patient is unable to deliver and she's having prolonged second stage of labor, this is an indication for vacuum assisted vaginal delivery. In multiparous women, it refers to lack of progress with or without regional anesthesia, or 1 hour without anesthesia. Not assuring fetal NST testing, suspicion of immediate or potential fetal compromise is an indication for operative vaginal delivery, when an expeditious delivery can be readily accomplished. Of course, the indications of vacuum depending on the the stage of labor she is, whether all the criteria are fulfilled, that we have to see before taking a decision on vacuum delivery. Elective shortening of the second stage of labor whenever pushing is contraindicated because of any maternal cardiac or neurologic disease, or simply maternal exhaustion. It is very largely subjective and not defined. But those of us who monitor labor day in and day out, we know what maternal exhaustion is, and it is for real. Sometimes the mother just gives up the this to push the. So we need to assist her from below with the help of a vacuum delivery. So coming to maternal indications, maternal distress, exhaustion after a long, painful, or sometimes even inefficient uterine contraction, prolonged labor, multipara, as well as nulliparous, maternal medical disorders, previous cesarean section if she has gone in active labor, or sometimes genital prolapse repair has been done, intrapartum infection, certain urological conditions, anywhere where you don't want the patient to keep on pushing or prolonging the second stage of labor, wherever we can cut short the second stage of labor, then we can apply vacuum. Fetal indications, if there is an umbilical cord prolapse and patient is near fully dilated, premature separation of placenta, non-assuring fetal heart rate pattern, fetal distress. Some vacuum even helps rotating to a certain extent, and occipito-posterior also sometimes we can rotate with the help of a vacuum. But of course, wherever we are talking about indication, there are going to be contraindication as well. Operator inexperience, I find, is a most important thing. Most of our residents, they are okay to do MTPs, they are okay to do cesarean sections, but ask them to apply a vacuum and they say, no, I would rather do a cesarean section. Inability to assess the fetal position, if there is so much caput that we are not able to assess the fetal position, suspicion of cephalopelvic disproportion, any coagulopathies, preterm babies because of risk of intraventricular hemorrhage, macrosomia, because nowadays India being the diabetic capital, gestational diabetic capital, we are seeing so many babies where the shoulder pad of fat is more than the biparietal diameter. Therefore, you might be able to pull out the head with the vacuum, but then you will get caught with a shoulder dystocia. Even slightly normal weight, like babies, 3.1, 3.2 kg babies in a GDM mothers nowadays, we are facing shoulder dystocia. Therefore, this has to be completely evaluated before we decide to apply vacuum for the patient. Soft tissue obstructions in the pelvis, any mass, breech presentation, face presentation, of course, is a contraindication to use vacuum. Absolute contraindication is underlying fetal disorders like alloimmune thrombocytopenia, demineralizing diseases like osteogenesis imperfecta, failure to fulfill all the requirements for the operative vaginal delivery, like an incomplete dilatation of the cervix, intact fetal membranes, unengaged vertex, any abnormalities of labor like malpresentation, suspected pelvic disproportion, gestational age less than 34 weeks or fetal weight less than 2.5 kg, or if for some reason the patient and her relatives do not want vacuum for their patient, then we have to, it's a contraindication. Relative contraindication is macrosomia, uncertainty of fetal position, inadequate anesthesia. Of course, we don't use any big anesthesia there. Prior scalp sampling or multiple attempts at fetal scalp placement, then this can cause injury there. Hence, we cannot apply vacuum in these patients. The prerequisites for operative vaginal delivery are very, very strict, and we have to see that we adhere to it. Like cervix should be fully dilated, membranes ruptured, engagement of the fetal head. The clinician has determined the position of the fetal head. Fetal weight estimation has been done previously. Pelvis is adequate for vaginal delivery. Anesthesia, if an epidural or local, we have to use. Maternal bladder is completely emptied. Patient agrees to the procedure and gives consent, and a backup plan of failure is there in place, typically a cesarean delivery, where the patient can be moved fast from the table to the OT table, or rather we can even apply the vacuum in the OT table. If it doesn't succeed, then we can go ahead with a cesarean delivery. Now, there is classification of operative vaginal deliveries. We all know about this classification. The outlet we apply, what we apply is entirely outlet nowadays, but even that can be classified as low, mid, and high. For same is the classification for both the forceps as well as the vacuum. Now, there are various types of vacuum extractors. We all know in our residency, we used to use the cup, the cup, which was a Malmstrom cup. But depending on the type, they are either metal or plastic. Metal cup vacuum extractors, or the soft cup, which is now available, the Silastic cup extractors. So this is basically a Medivac with the tube and the soft cup. And the center picture shows how the vacuum cup, the Silastic cup, is applied to the fetal scalp and the position where the cup is to be applied to the scalp. Now, depending on the type of vacuum cups for operative delivery, of course, there are so many brands which are available. It is called Gentle Vac, which is called Kiwi Pro Cup, with Mitivac, Mitisoft Bell. Then there is something called Secure Cup, Silac Cup, Soft Touch, Tender Touch. Then there are rigid cups like Flex Cup, Kiwi Omni Cup, Malmstrom Cup, Mitivac, rigid posterior cups, Bird Cups. So there are various names which are available, and all of them have got various specifications, but most of them are anywhere, the diameter is between 50 millimeters to 60 millimeters for better application to the fetal scalp. The instrumentation, the components we all know is a suction cup with 4 sizes, 30, 40, 50, and 60. Typically in metal cups, we used to have sizes, but the Silastic cups comes as a large, small, and a medium size cup. A vacuum pump is required, and the traction tubing to maintain complete traction. Then this is an extractor we all have seen in our labor ward, and time and again we have to review this extractor and see that the vacuum is functioning properly. Otherwise, if we start using it only when the patient becomes fully dilated, it is very, very difficult and it doesn't work. Then there is a failure of vacuum. The technique is very, very important. The woman's bladder has to be empty. The patient is placed in lithotomy position, vaginal examination to check the pelvic caput, the dilatation, presentation, position, degree of flexion, and that the membranes are ruptured, determination of the flexion point or where we want to apply the vacuum cup. So this is the flexion point, 2 to 3 centimeters in and around that we apply the vacuum cup. So the largest cup that can be easily passed is introduced sideways into the vagina by pressing it backwards against the perineum. We know we have in the soft Silastic cup, we can compress it with our hand and we can introduce it sideways, and that can be, attached to the head. Be sure, very sure, there is no cervical or vaginal tissue. So, we are taught that you have to move your hand all around the cup to make sure that there is nothing caught. In addition to the fetal scalp, there is no cervical or vaginal tissue or umbilical cord or a limb between the cup and the traction and the fetal scalp. So proper cup placement of the flexion point is the most important thing. It comes with experience. It comes with not giving up, and it comes with, we have to train our own selves. Every time we can apply the vacuum cup better and better. We have to exclude maternal soft tissue tissue entrapment by palpation. Then we create the vacuum. It has to be increased slowly. A check is made by using the finger around to ensure that no cervical or vaginal tissue. Sometimes when we apply, no cervical or vaginal tissue will be there. But when we cause the traction or when we cause a suction in that, they can come and get stuck to that. So we may have to put the finger around it once before causing the suction and once after the suction is fully built up to ensure that you are pulling only the fetal head. The pressure is gradually raised. The scalp is sucked into the cup and a caput succedaneum is produced, which actually disappears within a few hours of birth. The instrument handle is grasped and a gradual traction is given. One of the main differentiating factor between the vacuum and the forceps is that the patient has to have a make an effort to push the baby in vacuum, whereas in forceps that may not be required. This is how we check whether the traction the suction is fully working. You have to look at the needle, whether it moves completely and a good amount of suction is built. Episiotomy may be needed for the proper placement. Otherwise, some people give episiotomy till the head stretches the perineum before the head is just delivered. But however, we have to decide when we want to give the episiotomy, either before you put the cup or after you put the cup, but it has to be given. And one of the indications for episiotomy is operative vaginal delivery, and this will minimize the unnecessary blood loss. Traction is initiated by using a two-hand technique. Traction must be at the right angle to the cup. The traction directed initially downward and then progressively extended upward. It follows a curve of the caress, the curve of the caress through which the head passes downwards, backwards, downwards, and then downwards, forwards. So the vacuum, the traction has to mimic the normal vaginal delivery, and the head is gradually pulled down. So this is how a Malmstrom cup is applied at the fetal scalp, and then the traction should be synchronous with the uterine contraction. When she is pushing and there is a height of uterine contractions, we have to take maximum benefit, and it has to be released in between the contraction. Once the head is extracted, the vacuum pressure is relieved, the cup is removed, and a vaginal delivery is conducted. So the total time from application until delivery should not exceed 20 minutes. If more than 20 minutes, the risk of fetal scalp trauma is there and intracranial damage is there, and therefore we have to assess this particular patient and take a fresh decision. Many pulls to achieve progress should not be done. It should be a continuous process. Slowly we can feel the fetal head descending. The operator should be willing to abandon the procedure if it does not proceed easily and the cup dislodges or the suction breaks, between the scalp and the vacuum for more than 3 times. Don't bring your ego in between and say, how is it that I'll use it and I'll deliver it? No, it's not there. Don't bring in your ego, leave it, abandon it, and try to look for some other method. So when the head is delivered, the vacuum is reduced as slowly as it was created using the screw, as this diminishes the risk of scalp damage. And the chignon should be shown to the relatives and explained that it is because of the vacuum cup, and then it will soon disappear. Now, what happens if there is a failed vacuum? And then you have to do some other form of assisted delivery. So vacuum assisted delivery is a subgroup, or like it's something like a second stage cesarean section. So remember, a easy vaginal delivery could be an easy cesarean section, but a difficult vaginal delivery will be a difficult cesarean section. The answer to difficult vaginal delivery is not a cesarean section, because these cesarean sections are not going to be easy, and we need a lot of experience to do these difficult cesarean sections. Now, this occurs very rarely. This type of second stage cesarean section we may have to do very rarely, and it occurs in 5 to 10% of cases of whom we give trial of vacuum assisted delivery. It necessitates an emergency cesarean section. Cesarean section after failed vacuum is associated with worse tears to the maternal and even adverse outcomes to the fetus is known. The lower station of the fetal head makes the lower uterine segment very thin and stretched. So there can be an extension and of the uterine incision, and failed vacuum assisted delivery can have additional adverse effect on the maternal and neonatal outcome, not only in this delivery, but in subsequent pregnancy also. So the answer to failed vacuum assisted delivery, even if it is a cesarean section, remember that cesarean section is going to be very, very difficult, and we have to proceed very quickly. The decision making is very, very important. Don't waste more than 20 minutes, or 3 times if the cup has slipped, then we must not continue with that type of vacuum delivery. Now, sequential attempts at instrumental vaginal delivery. Now, I have seen some people apply vacuum once, vacuum twice, bring the station little bit down, little bit rotation occurs, then they use forceps or some other form of assisted vaginal delivery. ACOG does not support multiple attempts at delivery using different instruments, because there is a higher rate of maternal and neonatal injury. Initial small clinical studies, they fail to demonstrate any positive effects from combined or sequential vacuum for these deliveries, but larger studies, they say it is not good. Subsequential use of vacuum and forceps are associated with increased risk of both neonatal and maternal injuries. So routine use of vacuum extraction during the cesarean delivery, it's a very good instrument if used during cesarean deliveries. It can be used at the time of cesarean deliveries as well for high unengaged fetal head or a floating head as an alternative extension of hysterotomy when delivery of the vortex is there. Once the head is visible through your uterine incision, vacuum device can be applied directly on the vortex, and then with an upward traction, we can deliver the baby. Although such an approach may reduce the risk of extension, it's not recommended for all cesarean deliveries, but in floating head, fetal head, elective cesarean section, floating fetal head, vacuum can also be used for delivery of the baby. So in summary, it goes as A, B, C, D, E, F, G, H. A is if you are going to plan for a vacuum delivery, ask for help. Please get 1 or 2 more person who's going to help you if there is a complication. Address the patient. Look at the anesthesia part of it. If your patient is not under epidural, you can give local and pudendal block. Empty the bladder. Cervix should be fully dilated. Determine the fetal position and think shoulder dystocia. Most important thing, think shoulder dystocia. Extractor and resuscitation equipment should be ready. You have to apply the cup on the flexion point. Gentle the proper axis along the curve of the chest. Halt traction when the contraction is over. Halt the procedure if it is not progressing normally. So these are the complications of vacuum. This is a caput succedaneum. The first one here is a caput succedaneum. This is a cephal hematoma, and there can be even subgaleal hemorrhage and intracranial hemorrhage in a very difficult case or a large baby. So what are the fetal complications? Scalp laceration and bruising, subglial hematoma, cephal hematomas, intracranial hemorrhages, intraventricular and cerebral hemorrhages, retinal subconjunctival hemorrhages, and neonatal jaundice, because this bleeding has to be metabolized by the RBCs have to be metabolized by the liver. There can be clavicular fractures, shoulder injury, foxy, and sometimes even IUFDs or fetal deaths. Maternal complications are soft tissue injuries like cervical tears, extension of the tears, annular detachment of the cervix, vaginal tear, perineal laceration, extension of episiotomy, vaginal wall, perineal hematomas, traumatic PPH, infections, and genital prolapse. Management. So how do you manage these complications in the mother? We have to assess the effect on the mother and the fetus immediately after the vacuum delivery. We have to start ringer lactate solution drip, arrange for blood transfusion if she's bleeding. First and foremost, we have to exclude rupture of the uterus to assess if procedure is to be abandoned, and we have to consider delivery by cesarean section. Laparotomy should be done in a case with the rupture of the uterus or suspected rupture, and we have to administer parenteral antibiotics. There are a lot of advantages of vacuum extraction. It is easy to learn, much easier than the forceps. Quick delivery, less neonatal craniofacial injury, less maternal discomfort, less genital trauma, less anesthesia is required. However, the maternal bearing down effort is very much required for vacuum, which is not required for forceps, and therefore forceps has a higher rate of successful vaginal delivery if rotation has already occurred. If rotation is still remaining to occur, then vacuum could be a better option. So now this is a comparison of forceps, vacuum, and what is the difference between them, which cost effectiveness, the cesarean section rates, the uterine rupture, hemorrhage. You can see most of what is comparable, but the uterine rupture is more in vacuum when compared with forceps. But other than that, the brachial plexus injury is also more in the vacuum when compared to forceps. Other than that, more or less, both have got comparable outcomes. And if you see this, the failure rate of vacuum when compared to forceps, we can see that the failure rate with vacuum is much more than that of a forceps. If the forceps blades have locked, then you can easily deliver the baby. That there will be a genital trauma and extension of the tear with forceps is a different thing altogether. But the delivery or the failure to deliver the baby is more with vacuum than that of with forceps. So to conclude, an operative vaginal delivery should be performed if there is an appropriate indication. No indication is absolute because the option to do a cesarean delivery is always available. A number of clinical situations exist in which operative vaginal delivery should not be attempted because of potential risk to the fetus. A series of criteria needs to be fulfilled, which we have to be very, very careful. Select appropriate instrument, the size of the instrument, the size of the cup. It depends on the clinical situation and the operator's level of comfort and experience with the instrument. Soft bell-shaped cups are associated with fewer scalp injuries and no increased risk of maternal perineal injury. Maternal perineal injury basically occurs with the speed with which they bring the head down. If we go very slowly, we mimic a normal delivery or we perform even better than a normal delivery, there is very little perineal injury that occurs. So soft bell-shaped cups should be considered. And vacuum assisted delivery is dependent on several factors like patient selection and the other technical considerations, like there should be electricity, there should be a suction, they should be able to build up the suction. A lot of these things are very, very important. Forceps doesn't need all that. There is evidence that instrumental deliveries increase maternal morbidity. The risk of maternal injury is higher with forceps when compared with vacuum. Vacuum assisted deliveries can cause fetal problems. So pediatricians should be notified whenever an operative vaginal delivery has been attempted and see that the delivery is attended by the pediatrician for a neonatal resuscitation. So what are the elements required for documentation? We have to write what is the indication for intervention, why we decided to intervene, what was the position and the station of the fetal head, the amount of molding and the caput that is present, that we have assessed the maternal pelvis and that we found it adequate, assessment of fetal heart rate and contractions, record the discussion with the woman of the risk, the benefits and the options, the number of attempts, first attempt, second attempt, third attempt, ease of application of vacuum and forceps, duration of traction, and the force used. And if at all there is a maternal or a neonatal injury, we have to describe that and document that in our paper. So documentation for operative vaginal delivery is very, very important. So thank you for a very patient hearing.
Thank you, Dr. Geeta. Such a elaborate and such a, it felt like that we are sitting in the medical college and learning the
and
listening.
Right.
Yeah, listening to our teacher, and you have explained in a very, very
Yes.
good way. And one thing I will just like to tell Dr.
I know.
Geeta, you have beautifully explained that
I know.
it is very, you've beautifully explained. Difficult normal delivery is a difficult cesarean also. If there is obstructed labor, we are finding difficulty in taking out the baby by vacuum or forceps, there is difficulty during the cesarean section also. So beautifully explained. And in our country, in low resource setting of our country, the accessibility of these things are very, very important. And many times they have saved us. They have saved us from litigation. Sometimes patient is not able to bear down, and applying all these vacuum extractor really helps us. So very well explained, Dr. Geeta. And I think it is very important to understand prerequisites and when we should stop this procedure. This is very important. And as far as you have beautifully explained that all the residents should undergo this training. They are having training for cesarean section, normal delivery, everything hysterectomy, but they are not getting mastering in this process. There is a skillful art. doing all the application of these things. You have beautifully applied. We have to see all our finger around the fetal scalps so that any part of cervix or vagina is not coming in between. So very well explained. Wonderful presentation, Dr. Geeta. Thank you very much.
Thank you.
Yes, Dr. Aarti, if any comments. I think Dr. Vinita, madam, she was supposed to join. Is she there around? No.
Vinita ma'am, aap hain? I think ma'am probably was busy, so I think she got delayed in
No
joining.
worries. No, we got a message from her.
Yeah.
She's busy. So,
Dr. Geeta, but I would
Dr.
like to
Aarti, kindly
comment.
comment.
Yeah.
yes, Dr. Aarti.
Yeah, excellent talk. And it's the fact that the art of vaginal delivery is getting extinct at the cost of the science of cesarean sections. So it's very important for all the residents to keep vacuum and forceps handy in the labor room drums. And they should know when to use it and what is the right time to use it. And actually, it will definitely sensitize our PGs, our youngsters, more not to go for cesarean section promptly, like second stage fetal distress, prolonged labor. They should opt for operative vaginal delivery. Excellent talk. Thank you.
Dr. PK Shah, do you have any comments? Sir?
A place where they can get a good grasp.
Sir, sir is muted, I think. Sir is muted.
But you
Please
know, after
unmute,
that,
sir.
then I thought ki-
Arey, who's
Geeta, you have covered it very well.
Sir.
And you were there with us for a short period at Sion Hospital.
Yes, sir.
And I had brought a Mitivec. I don't know whether you remember this name.
Yes, sir. Yes, sir. I remember, sir.
Mitivec, whereby you don't spend time. Like 8 minutes we used to use when we used to use
Wait for
vacuum.
to build.
So Mitivec, I brought it. It was 10,000 rupees in those days when I was at Sion. And it was excellent. Absolutely fantastic. I don't know whether it is available now or not. I don't know whether anybody is using it or not.
Yes, sir. Yes,
It
sir.
was excellent.
Yeah.
Yes.
It's a small cup. Now it comes for 5,000 rupees, sir. And it
Yeah.
can be used on 2-3 cases. It's very nice.
It is worth it.
Yes, sir.
Yes.
Yeah.
So wonderful talk, Dr. Geeta. I mean, I'm very happy that you did the best. I would just share my practical experience that when I was the chief resident at Sassoon Hospital, me and Parag, where we were, in different units. So our guide has made sure that I teach at least 500 forceps application and ventus to my juniors, and we have made a paper also for that. She said that you make sure that these instrumental vaginal deliveries are no different than normal vaginal deliveries. That expert the resident should be. And we are proud to say that, we had those kinds of teachers like PK Shah sir. So we really feel that, the teachers now should take up this, it is high time now. I would ask Parag to make a few comments and of course a few words. Parag has just joined.
Thank you, Sneha. First of all, apologies for joining late, but I am happy that I joined late because I could listen to Geeta's excellent presentation. Geeta, it was wonderful as usual, and it shows the hardcore teacher that you are, and I'm sure the students at Wadia are getting trained so very well in assisted vaginal deliveries. My warm regards to Dr. PK Shah, who's the chief guest, and very dear friend, Dr. Sarveshwari, and of course, all other friends from Uttarakhand. I bring greetings from Amogs, and as national coordinator of Amogs, it is wonderful interacting with all the friends from Uttarakhand. This year, Amogs has crossed boundaries, and we've tried to connect to other states. And Sneha, as chairperson of Amogs Emergency OBGY Committee, is doing an excellent work. And I appeal to everyone sitting here to vote and support for her because she really deserves to be there as the vice president. And of course, with the blessings of seniors like Dr. PK Shah, I'm sure Sneha, you'll do wonders this time. Thank you very much for the opportunity.
Thank you so much, Parag. Thank you so much.
Just want to say one word.
Yes.
We welcome you, Parag. We were waiting for you in Dehradun, but
I
we
know,
really
I know.
welcome you. And
My son came down from Canada, so I had to miss it.
yeah, and your words are perfect for Sneha. Sneha is such a person who should win.
Yes.
Thank you.
Sneha, please carry on with the person.
Thank you so much, everybody, for your blessings and best wishes. Once again, I thank Dr. Geeta, for such a wonderful session. And
One word I want to say for Geeta, you took me back to the labor room. That's all. You took me back to the labor room.
Yeah. Yes,
It
madam.
was so lively. The description was so lively. You have heard me. It was very nice. It was very
Yes,
lively.
sir.
As if I'm
Thank
standing in labor room and every whole process is going on. Okay.
right.
Thank you.
All-
Thank you.
Yes,
So
madam.
over to
Thank
you,
you, madam.
Radhika, for introduction of the panelists. I think Dr. Parikshit has just scrubbed for the ruptured ectopic, and he will be taking over after the panel discussion. So we can go ahead with the panel discussion.
We'll move ahead with our next session, which is the panel discussion on near missed cases, the case scenarios. And we have our very dear Sneha ma'am, who will be the moderator. And we have two very extremely learned and senior chairpersons with us, Dr. Anudhir ma'am, who was the past president, very senior member of Obs and Gynae Society, Dehradun, and our very dear ma'am, Dr. Suman Sethi ma'am. Both of them are such active participants of the society and are always there for us juniors. We welcome you. And we have with us 6 dynamic panelists who have, at the very short notice, accepted to be panelists, and they've read up past few days on these cases. I welcome Dr. Swati Agarwal, ma'am. She's assistant professor from SGRR Medical College. I welcome Dr. Priyanka Singh. She's a private consultant, senior consultant at Dev ENT and Maternity Center, Dehradun. Dr. Pallavi Singh, a very charming, sweet person, consultant, Pink Clinic, Dehradun. Dr. Achal Agarwal, a very learned assistant professor from HIHT Himalayan Institute, Jollygrant. Very dear friend, Dr. Rajlakshmi Mundra, additional professor, Obs and Gynae, AIIMS Rishikesh, and our very dear dynamic secretary of the Uttarakhand Gynae Society, Dr. Archana Singh ma'am. And ma'am also had a very big role to play in the FDCon here, and she's always there a call away. Thank you so much, Archana ma'am, and we welcome all the esteemed panelists to this panel, please.
So a very good evening to all of you. My respects and regards to Madam Jyoti Sharma. I think I could not see her.
No, she's here right next to me.
So Madam, pranam to you. I was waiting to meet you.
I was a silent spectator. I've been listening
Your
to
blessings matter a lot for us, Madam. Thank you so much for joining. And of course, I welcome all my panelists as well as my respected experts. And without much ado, we would like to go straightway to the panel discussion. I hope you can see my screen, and it is full screen. So friends, I'm sure that all of you will agree to me that you just feel, that this lady will deliver in a short while, and you are happy. In no matter of time, you can see her in ICU. That is how unpredictable obstetrics is. And that's a very reason you have to be really, really very alert, very vigilant on monitoring your patients. Friends, you know that the maternal mortality was so high. It was around 513 3 decades back, around 300 2 decades back. But last decade, now we have come down much, even though today India's maternal mortality rate is 97, less than 100, but in some parts of country, that is Northeast and Northeast especially, it is more than 200. And even Uttar Pradesh, it is slightly higher. Maharashtra is 33 and Kerala is 19. These are, to be really happy moments for us. But maternal mortality rates, friends, we are talking about it. So these are not just rates and ratios, and these are not just numbers and figures, friends. These are women. They have their faces, and we obstetricians have seen these faces in the faces of their distress, agony, and despair. So these continue to haunt our dreams. That is what it has been expressed by the past president figure, Dr. Mohammad Patala. And similarly, looking back over the clinical times, one tend to forget the failures, in fact, take it for granted the success. But these are the failures which stand out like keloids. They keep keep on warning us, and of course they keep on warning the others also. So they keep on reminding the person who has faced it. So friends, we are talking about near miss case scenarios, and this actually means a pregnant or a recently delivered woman who would have otherwise died had it not been the luck and the good care on her side. Near miss, actually, this is a terminology we have borrowed from the airlines industry, and both the planes crossing each other, and it tells you the gravity of the situation, how serious it is, and the urgency of intervention it is needed. And that is why this terminology has come up. So without much ado, all of us will learn together, because you have to be ready for learning, because life never stops teaching you. So with this, we go with the first case here. Our first panelist, Dr. Swati, will be taking up this case. This is just a warming up quick case. Second gravida, previous cesarean section, last childbirth only 1.5 years back. So she comes to you as comes to the doctor as 7 days overdue with urine pregnancy test positive, and she asks for the medical abortion. So the doctor prescribes MTP pills and calls her after 7 days. So meanwhile, she doesn't get any bleeding, only spotting, giddiness off and on. And on 6th day, she was called on 7th day, but on 6th day, 11 p.m., she is brought to the hospital in a collapsed condition by the relatives. What do you feel is the diagnosis? The clinical condition is that she's got tachycardia, pulse rate 132, blood pressure is only 90 by 50, and blood pressure is only 70, and she's got severe pallor. So what is your differential diagnosis for this case, and how do you manage this case?
Good evening, very good.
Good evening.
Good evening to everyone. There is a typical triad of symptomatology present. That there is amenorrhea, there is bleeding PV, and there is pain abdomen, and other supporting systems like symptoms like giddiness also present, and UPD was positive. So this is a case appearing to be a case of ruptured ectopic associated with the examination finding of hemorrhagic shock. But sometimes there can be other differential diagnosis, if there is doubtful UPD test, there can be ruptured corpus luteal cyst, which often we get around the day of 28 or around the date of their expected menses.
Right.
And sometimes there is ruptured ovarian cyst, ruptured chocolate cyst. Once we got ruptured chocolate cyst,
yes,
where on the paracentesis we get we got.
Looking at the clinical
Pardon?
presentation, looking at this clinical presentation of shock, do we have these differential diagnosis, Dr. Swati?
At present, almost my diagnosis is this is a ruptured ectopic pregnancy case.
Yes, a ruptured tubal ectopic pregnancy, that is the first diagnosis, but you can have a second differential diagnosis of scar ectopic, because she's a case of previous cesarean section.
Scar ectopic.
Right.
Yeah.
Okay. So how will you go ahead with the management?
So here, because the patient is in shock, the investigation and resuscitation will go hand in hand. So we should start the resuscitation, and simultaneously we should advise the other investigation. The investigations are the routine blood investigation. Already UPT was positive. For this patient, I won't go for serum beta HCG, but there is a value of serum beta HCG. We should advise it, and we had to follow after the laparotomy or laparoscopy, whatever the procedure we are going to do. The ultrasound for this patient, if we have availability of ultrasound in our in-house, then we can go for ultrasound for medical legal reason. But otherwise, this is a clear-cut case clinically as for ruptured ectopic. We can see for other findings like there is a tenderness, per abdomen tenderness, cervical motion tenderness, or coltocentesis whenever required if the ultrasound facility is not available. The routine blood investigation, viral markers, the coagulation profile, and other tests we will get done.
Yes. So so you have confirmed the diagnosis of ruptured ectopic pregnancy, whether you would like to go ahead with the laparotomy or laparoscopy, and whether you would like to go for the conservative surgery or sulfingectomy. How would you decide that?
for this particular patient, I will like to go for laparotomy and for the salpingectomy.
Okay, but
Because the
suppose
patient is in shock, and we are at, according to her vitals, we are expecting the huge amount of hemoperitoneum. But otherwise, when patient is stable, we can go for laparoscopy, and depending on the size of rent or the amount of, like, whether it is tubal abortion or actual tubal ectopic ruptured pregnancy, we can decide whether we should go for salpingostomy or salpingectomy.
Correct. Correct. So if it is a rupture, you have to go ahead with the salpingectomy for sure. If it is a tubal abortion, but will you not agree to this point that, you know, the very fact that she has developed ectopic pregnancy, that means there is some problem with the tube. There is some tubal damage, maybe may not be externally, but maybe from inner aspect as well. Okay, so I would appreciate all your discussion. Only I would like to tell you one thing, that suppose you know the gynae endoscopic surgeons nowadays, the laparoscopic surgeons, they claim that even if it is, you know, massive hemoperitoneum, we are able to suck out the blood at once and, you know, go ahead with catching the bleeding point fast. So what is your take on this?
Yes, ma'am, I agree with it. The thing is, the anesthesiologist should be able to give general anesthesia in this condition of the patient in shock. And if your expertise in laparoscopy is there, you can proceed with the laparoscopy also.
Correct. So it is, I mean, it is depends on whether you have the availability of the expert laparoscopic surgeon or you yourself is a expert laparoscopic surgeon. And then of course things should be settled. And of course it's a choice of the patient. You don't have to take into consideration for such life-threatening conditions, right? So very well discussed case. I would just ask you the last question now. If you introspect what has gone wrong for this patient, whether we could have prevented this condition, you know, she has landed up into shock, blood pressure of 70. If she had not received this proper care, we could have lost her. Correct. So what is this simple technique, simple thing rather, that was missed here? Whether we could have prevented this, I'm asking you for this patient.
So it's difficult to prevent an ectopic pregnancy, but the thing is, we could be able to diagnose it early.
No. I'm not asking you that difficult to prevent the ectopic pregnancy. She already had an ectopic pregnancy.
Yeah, we can diagnose it early.
You are prescribing the empty pills. MTP pills you are prescribing. Okay. That is why she has landed up into this condition in this case.
Yes, ma'am.
So whether you could have prevented this?
Yeah. So before prescribing MTP pills, we should be very sure about the localization of the pregnancy, whether it's intrauterine or in the tube or any other site.
Yes. So how do you do that?
So usually, ma'am,
ultrasonography, right?
Actually, at my setup, we used to prefer at the as soon as patient comes to us with the missed periods, at the end of 5 weeks, between 5 to 6 weeks, we advise a transvaginal ultrasound. Though other side, it's not routinely advised in guidelines, but the guideline says you can do a examination, per vaginal examination, though a lot of patients are uncomfortable with that. So either you should rule out with the local and per vaginal examination whether there is any tenderness or not, or easier thing is by a trivaginal ultrasound.
Sometimes you may
and the cinematized CT.
Sometimes you may miss such an early ectopic pregnancy on clinical examination, even with internal examination, correct? So yes, ultrasonography is a must here. Though guidelines say that it is not a must, it is recommended for the safety of the patient and for the safety of the doctors, right? So our learning lesson for this case that we should go ahead with ultrasonography and the basic investigations at least before prescribing any empty pills. Correct? So thank you, Dr. Swati.
I have to add something here. That even if giving her empty pills and she did not bleed for another 6 days, so she should have gone for an ultrasound after 1 or 2 days if she had not bled after taking empty pills and she had not passed the routine.
This patient was getting spotting, no? So she must have thought that now the spotting has started and she will start bleeding. That is what the patient must have thought. But the message we want to give, that is very clear, that unless you rule out ectopic pregnancy, please do not prescribe empty pills, correct? After prescription of the empty pills, there is no point. It's going to rupture sooner or later, correct? So we go ahead with the second case now. This is a case, 36-year-old woman who is conceived with IUI. The husband stays in Dubai and she stays in a village. But because this is a precious pregnancy, she came for regular NC checkup up to 24 weeks. And the obstetrician says that things are fine. So she is lost to follow. Now, when at 34 weeks, she comes to the PHC at a local place where she comes to the doctor for pedal edema. When they examine her, the blood pressure is 176 by 116. The fetal rest, everything they feel is normal because, there they do not have much facilities to investigate. Her BP was measured as PSC was high and they started her on tablet nifedipine. Okay. She was advised admission at a higher center, so she was not willing, so nobody bothered, So she did not get admitted for another 1.5 to 2 days. After 2 days, she got admitted to a higher center, that was a sub-district hospital. There they had anesthetic, so they added to it tablet labetalol. So now this patient is on tablet nifedipine, tablet labetalol, and because the BP was still 180/110, they gave her magnesium sulfate. Cesarean section was done. Baby was delivered, 1.8 kg female baby, and within around 20 hours, that is not 30, 20 hours, she suddenly became breathless. Pulse rate was 150, blood BP was very high, 220 by 118. Oxygen saturation gone down to 70%. Her chest was full of wheeze, no clear breath sound. So, Dr. Priyanka, what is your differential diagnosis and how will you manage this case?
Thank you so much for the question, ma'am. Greetings from Dehradun. Thank you, Sneha ma'am, Sunita ma'am, Raminu ma'am, dear Radhika, all of you, making me part of this. I just joined this because of you, ma'am, because this is a very nice learning session that you're taking up for us. Ma'am, according to the whole scenario, it looks like a patient that with a high BP was being taking antihypertensives, who's conceived with IUI. So the patient here lands up into pulmonary edema after 30 hours of C-section. Ma'am, DD will be pulmonary edema, maybe pulmonary embolism if something we have missed out in the past.
Yes.
Immediately, if we see the patient in such a condition, we can definitely make a diagnosis clinically for being a pulmonary edema. But to differentiate it with pulmonary embolism, we'll definitely look on for certain investigations further.
So how will you go ahead? Now this patient is in this condition. So rather than investigation, you need to first manage her. So what ABC,
yes, the first
initial management, what you will do?
First of all, this patient should be taken up in a tertiary setup. It shouldn't be managed in a smaller setup with such high BP issues. And
but then now that she has landed up into, she has landed up into this condition, you can't refer her.
Yes, ma'am.
You have to stabilize her first. Yes. So how will you do?
The first thing is the stabilization of the patient. So we'll first of all make the patient ABC. We'll try to maintain the ABC of the patient, propped up the patient. High flow oxygen will be given. Stop all the fluids that have been given. If magnesium sulfate is going on, we'll have to stop that immediately. Or excessive fluids that have been going, that we have to stop. And injection Lasix will be given immediately. Oxygenation is needed.
I will interrupt you in between. How much Lasix?
60 mg to 80 mg, ma'am.
Yes, at least 40 milligrams or 40 to 80 milligrams.
Immediately we have to also alert the whole team. We have to ask our anesthetist to come up immediately, ask our helping sisters around to come up with the basic resuscitative measures together. Tell the attendants that please beware, this is the condition. We might need to shift the patient to ICU immediately. We need certain resuscitative measures to be taken as soon as possible. We'll inject injection labetalol, ma'am, to control the BP first, because that can be very devastating for the patient. So injection labetalol will start like, ma'am, we have to start like 20 mg stat. Watch for like 5 minutes and so. And then, ma'am, then increase to 40, 40, 80, maximum of 220 mg, so
Yes.
that the blood pressure comes under control immediately, as much as soon as possible.
Correct.
And yes, ma'am. Then
Now
we
that
try
now
to
that you have stabilized the patient, by the time your team who is arranging for the investigations, the bedside echo,
Right.
bedside X-ray, and
chest X-rays,
everything.
yes, ma'am.
So I'm sure you must
Investigation.
have called along with your anesthetist. You must have called your physician or intensivist there. Though you
Right,
can
ma'am.
shift
Yes.
the patient to ICU, first they will manage it here. Correct. So
Yes, ma'am.
they will try and stabilize this patient. So while everything was going back, this was such a catastrophe that even with this management, the patient, suddenly she went into cardiac arrest. Now how will you manage? Yes, they wanted to
Ma'am,
shift
we'll
to
definitely,
ICU, but she went into cardiac.
yes, ma'am. But ma'am, if our anesthetist is there, we'll start CPR immediately. That it is a cardiac arrest.
Right.
We have to ensure, ma'am, certain things like CPR should not be in the room. We have to at least shift in the OT premises where we have some things like if we have a defibrillator around, we have all the emergency drugs around, we have anesthetist around. We have air where we can stand over the patient properly so that we have a height, so that we can give proper chest compressions.
Right.
And adequate
Priyanka,
compressions and
I agree to you everything except one point. You said it should be in OT. Do you remember nowadays for the public awareness what things are going on for CPR? You have to teach every non-medical personnel also, even the bygones who are there, the passengers on the way, right?
the CPR, yes, true,
Yes.
true, ma'am, true.
So,
So we can at least start the CPR immediately, when and where.
So I
wherever
think
possible.
not only the anesthetist or intensivist, even we should be able to perform. If the
Yes, ma'am.
non-medicals, then why not us? Correct? So you're
Yes, ma'am.
right. But then this point, I think you should give this message that all of us should know. I'll be very happy if you say that all of us should know CPR. And then how do
Yes,
you
ma'am,
give
we all
CPR?
doing
Yes.
CPR.
And
Yes,
then
ma'am,
how
but
do
there
you
are apps available where they're teaching CPR nowadays.
Yes.
It's an easy method and should be done immediately as soon as possible. That saves lives.
Correct. Correct. So how many compresses you give, chest compresses?
Yes, ma'am.
And where do you give them? What is the frequency?
Yes, ma'am. Ma'am, the CPR has to be provided at a certain height. The elbows should be straight. Both the hands should be below the sternum, and compression should be started. Yes, ma'am, below the sternum. There should be 30 compressions. There should be good, adequate compressions where
How do you know that?
chest should be.
How do you know that whether it is adequate? I'm sorry, I'm interrupting you, but for the house, we need to, the attendant should know it clearly. You said 30 compresses, perfect. They should be adequate. But how, the ribcage should
height of the
5 centimeter. It should be
centimeters
compressed.
should be the compressed.
Right.
Chest compression should be 5 centimeters. And after 30 cycles of chest compression, there will be 2 breath cycles should be given, which will constitute like a 1 cycle. After 5 set, we'll exchange. This takes a lot of effort. When you're doing it right, after 5, you cannot give adequate compressions. So the other standby, by the time if anesthetist come, he'll be taking up, or any other sister or staff should be taught to do that adequately.
Right.
And we have to look for the recoil of the lungs, ma'am. When we wait for the air to enter the lungs and inflate, so you have to watch for the recoil of the lungs. If it is not coming, then you have to again assess for the airways. Then you have to give a head tilt, chest, chin lift, whatever possible, or ambu bag to provide oxygenation to the lungs.
Right.
And if at all, ma'am, during this, if circulation is also getting hampered, then yes, we'll have to look for is according to that dobutamine or adrenaline maybe, or dopamine might be needed. Resuscitation as a part of the resuscitation methods.
You pointed out one very important point that your lungs should recoil, correct? That means your lung compliance should be good. But I just mentioned that, that there are no clear breath sounds. The chest is full of wheeze. So would you like to give something to this patient?
Wheezes.
The nebulizer? Nebulization with some...
Lasix? Nebulizer, yes, ma'am. Nebulizers we can give, yes, ma'am. Right. That we routinely give.
That will, it will facilitate.
We can give some steroids also, ma'am.
Yes, of course. Epcorlin, Vimizon, these are steroids will definitely help you to combat the inflammatory process, whatever is the So that is how.
Perfusion, lung perfusion.
Correct.
Yes.
So now your capillaries will open up, and your shock situation, what is there will be taken care. So you have covered everything, and now you have rightly managed the patient. So here also the patient was intubated by the anesthetist, and everything as you said was done. The patient recovered, came to spontaneous respiration within 1 hour, and blood pressure also came to 100/64 now. I'll just ask you, for this patient, right from the beginning, I will ask you to retrospect now. What went wrong in this management of this patient, not as pulmonary edema, as an antenatal care, as a managing obstetrician, what things have gone wrong, so that we should look for our patient?
Ma'am, in such patients, whenever there is IUI conception or IVF conception, right from the beginning, when we are doing a dual marker or a level 1 scan, during those scans, we can easily get the PI screening. The pulsatility index is a screening which usually nowadays our ultrasonologist provides the data with easily. It is screening positive for this or screen negative. That time you can detect easily, and from that time you can start ecosprin added from the initial days.
Now that I'm very happy that you picked up the predictor very well. Now that you have talked about aspirin, in fact, I would just try to little improvise on your discussion. That you, not to start from the gadget, start from the history. She's a 36-year-old lady, elderly gravid.
Yes, ma'am. Aged, elderly priming gravid. Yes,
Treated with IUI, some alternative techniques. And then, of course, if such a patient, the maternal characteristics, they are on the higher side, you score her as high risk for HDP. And then you start aspirin and high dose calcium right from the beginning.
Yes, ma'am, right from the beginning.
Okay, that was one. Very well picked up by you. And secondly, when she's diagnosed as, this patient should not have been told that everything is fine unless you do everything. And also, in fact, she should have been warned that she has to come for regular antenatal care visit.
Regular antenatal care. Right? Yes, ma'am, definitely. Once when she was admitted also, ma'am, that time also she would have told about the severity, and that time also injectable labetalol was started given, and magnesium sulfate was given, and the proper tablets were started, nifedipine capsules were started. Then all these things would have done better.
Very good. You said that, not the tablet nifedipine retard. Okay.
Not the tablet retard. No, ma'am.
They started with tablet nifedipine retard, and then it was not controlled, so started with tablet labetalol. So things went wrong there, right?
Went wrong, right, ma'am.
Right. Yes, and then, of course, when they were to, they have to take her for cesarean section. For such patients, they have to monitor the preload. It has to go very, very
preload has to be
right. And once they deliver the baby, of course, they have to use the proper oxytocin, not methergine, not carbamazepine also. As far as possible, this thing should be avoided. And once you deliver the baby, now you can safely give Lasix. Correct? Even when she is not in pulmonary edema, in fact, as a prophylaxis, you can give Lasix. Correct? So you have discussed this case excellently. I mean, you have missed only few points. For the attendees, I would just reel out that yes, our patient has developed pulmonary edema, which actually means collection of the fluid in the interstitial spaces of the lungs. And because these lungs are full with the fluid, it is, what is called as a compliance is reduced. And so the work of breathing is more. And because of all these conditions, it has worsened. So whenever you are managing such patients, you have to first check that the airway is patent, she is breathing. If not breathing, you have to intubate and give her mechanical ventilation and see that her circulation is well maintained. If not, then you can give her dopamine or dopamine infusion. By the time your one team is stabilizing this patient, the other team will go for investigations. As you have already said, that nebulizer, loop diuretics, Lasix, we have discussed steroids, Look at this, assisted ventilation, and then of course you send the lab, not only your routine lab, your liver enzymes, your renal function tests, etc., but also the cardiac enzymes. Okay, don't forget that even MI can manifest like this, and don't forget that even PCM, postpartum or peripartum cardiomyopathy, can also manifest like this. So all and all, you have managed this patient well, and that is why we could save her. So thank you so much, Dr. Priyanka. That was excellent input from your side. Yeah. Now we go to Dr. Archer. Okay, so we have this 20-year-old primary gravida, 9 months amenorrhea, referred to the hospital at 11 p.m. Okay, then on inquiry, she reveals that she was hospitalized at a nearby nursing home, maybe around 3 to 4 hours prior, around 3 p.m. That means 8 hours prior, and there was no there was failure to progress, so they decided to take her of course cesarean section. When the sister catheterized, she found that there is no urine, and on further inquiry, they found that since last 8 to 10 hours, she has not passed a single drop of urine. So this patient was shifted to the tertiary care center. When she came to the tertiary care center, the pulse rate was 110, BP was 110, 70, uterine contractions were very strong, severe in intensity, no relaxation in between. The fetal heart was only 100 to 120 irregular. The dilatation is, I won't say it is 7, it is 3 centimeter. It is wrongly typed here, 3 centimeter. Membranes are absent and there is brownish color discharge coming out. Station is 0. Okay. So, and we are also provided with the investigation. So what is your diagnosis here? I can ask Dr. Achal first. What is your diagnosis here?
Ma'am, by the clinical presentation, the diagnosis of abruption, that is definitely grade 2 and
Right.
progressing well to grade 3 in a few hours probably.
Yes.
And with already
So
set in coagulopathy is visible.
So
And
the investigation reports you get is hemoglobin is 8. You're right that she is a case of abruptio placentae with fetal distress and grade 2 to grade 3. Correct. So investigations provided are hemoglobin is 8 gram percent, platelets only 1 lakh, PGINR is 2, and APTT prolonged. FDP, fibrinogen degradation products are present and fibrinogen is low, 150. Now what is your diagnosis and how will you manage? Whether you, because for fetal distress, whether you want to take her up for cesarean section immediately or how?
Ma'am, we will have to take her up for cesarean section immediately, and along with all the resuscitative measures ongoing.
But then she has fibrinogen 150 only,
We will
FDP.
have to arrange for the blood products and blood ma'am accordingly.
That is what.
And then with that in hand and with an experienced anesthetist, with an
So
ICU bed,
everything has to be done simultaneously.
with the NICU person with us, matlab specialist needs to be there for everything. And this is a high risk case definitely. And then we need to go into the OT with all the preparation, but in a very less time. We cannot give her more time for, we cannot spend more time in preparing the patient. We have to do everything simultaneously and shift the patient as soon as possible to the OT and deliver her, because only then can coagulopathy be addressed properly once the fetus is out, and fetus is already having a heart rate of 100 to 120. So there is very, very severe fetal distress. So we will have to act immediately and get baby
And
out.
once you, in fact, once you deliver the baby, once you deliver the placenta, things will settle quickly.
Things will be better. And
Even further coagulopathy will be, it will be stopped.
And already at present, when the fetal heart has already gone down, there is a 15% chance that this baby may still not survive, even if we act immediately. So hence emphasizing the need of early management.
Yes. So as soon as possible, you have to take her up for cesarean section, provided you order for blood and blood component and see that they are going to get easily. And by the time you do aggressive fluid resuscitation for this patient.
If
Now,
piping
why?
mat is not available, pardon, ma'am?
This patient has got anuria, correct?
Yes. Yes,
so it's not, you don't have to wait for blood and blood component. By the time you have to go
start
for
crystalloids,
aggressive
ma'am.
fluid resuscitation.
Warm crystalloids, at least 1.5 to 2.5 liters we can do. Total of 3.5 liter blood replenishment, that is fluid replenishment, is advised. So
Now
at
you
least
tell me,
2 liters we
you
can
tell
give.
me that whenever you want to give such a high volume of fluid and that too so quickly, do you need to have specific arrangement for this?
First of all, we have to take the cesarean section up in general anesthesia, because respiratory part component will have to be very well managed. Otherwise, transfusion related lung injury as well as fluid overload lung injury, both are likely to happen.
Yes, yes. That is the reason I ask you this question, that whether we need to have some special monitoring. We are giving her aggressive fluid resuscitation, we are doing for her. We are giving her fluids, blood components, whatever. So do we need to have some special monitoring? That is invasive monitoring, CVP, right?
CTV, central
Yes,
venous.
that is what was the question. So now suppose you have so many challenges. What are all the challenges? I have enlisted, but what you could get?
The first challenge is getting the fetus out.
Right.
The second challenge is that the patient should not go into hypovolemia as well as lung collapse.
Right.
She's
She
already,
is already.
the hypovolemia should not worsen. We need to
Right.
manage the hypovolemia,
So,
coagulopathy,
yeah, so
and
that is because of hypovolemia and hypoperfusion, she has landed up into acute renal failure.
renal
This should
failure.
not go to irreversible, that is
This,
tubular
this
necrosis.
has to be corrected as soon as possible. But if we do proper hemodynamic management, if we do proper resuscitation, then most of these cases will come out of the acute renal
Yes,
failure.
very true. Very true. So this is what is the different grades, and these are all the challenges. So it's not only she's got the blood pressure is quite deceiving. It is saying 110/70, but don't you feel that it may be higher when you correct the fluids? Then you get the exact what was her previous blood pressure.
Probably
Because
she
the
was a
very
hypertensive patient,
right, this must
landed
be
into abruption during labor, and we do not know what her baseline blood pressure was.
correct, correct. So once you correct her hypovolemia, you will get her the basic blood pressure what actually it was, and then of course you can prevent the renal ischemia and all those things you can correct. Then you will try to revert her coagulopathy by giving blood and blood components. Now I would just ask you any other precaution during the procedure.
Hemostasis might be very difficult to maintain if there is already setting in of ovular uterus, if the coagulopathy has worsened.
Anything else you want to give? Any injection you want to give before the procedure? Tranexamic acid?
Tranexamic acid may or may not work, but we will still like to use it.
Yes, because something is better than nothing. Yeah,
Yes.
though sometimes you may have to give it, but tranexamic acid, you said it may not work. So what is the reason behind this?
Tranexamic acid, ma'am, it helps only when the coagulopathy is less severe. Right. At this point, the patient already is in need of fresh frozen plasma, cryopressure maybe.
Yeah, but
If,
then see the score. If you score this, no, the platelets are 1 lakh.
Yes, ma'am.
Right? Epithet is not so prolonged. PTINR is only 2. Many of these patients, she is just in early coagulopathy. That is why I ask you this question. And it is also the standard of care for PPH, right? Giving 1 gram of tranexamic acid because this is a patient who has landed up into APH, and after the seizure, you rightly said covalent uterus, atonic uterus, and then of course the coagulopathy, all this will add and lead her to PPH, right?
Acid should be given.
Yes, so it should be given. So you are putting in 2 large bore IV, this everything you have managed, but do give this tranexamic acid also, not to give methergine, that is our standard of care. But sometimes when you don't find that the uterus is not contracting, even with carbetocin, you give carbetocin, you give oxytocin, everything. In those situations, methergine definitely helps, right? Because contraction and retraction, and thereby the crossing of the vessels with the muscles, they contract and retract. So definitely it helps in these cases, preferably. Okay, so I think we have managed this case very
Just one query.
Yes.
As this patient might have been hypertensive to start with, will it be safe to give methergine even as a last resort? Just my query.
Yes, definitely. See, see, if you try to analyze that, if she bleeds like a tap, all of you know what obstetric
life-saving.
emergency is. Okay, even with compression, packing, everything you are trying to do, give massage, is that if nothing helps in that, you say prayers. So why not to use methods?
It is worth an attempt.
Yes, and if the blood pressure goes high, you have IV labetalol. All of you are very worse now. The capsule nifedipine also 10 mg, orange color capsule 10 or 20 mg as per requirement, but that will lead to uterine relaxation. Correct? Nifedipine will lead to uterine relaxation. I'm sure it is your practical experience as well, but definitely you have the injectable labetalol. Okay, so at this point of time, when you are not having
When we are
hypertension,
contemplating.
in fact the patient is having hypertension, you need not worry about the hypertension. Correct? We have to manage the bleeding, whatever. This is the crisis at present. So I'm saying, not as first drug of choice. First drug of choice is carbetocin, and then of course the concentrated infusion of oxytocin, as you have said. When people are recommending 800 milligram of misoprostol per rectally or so, then why not mithazine? Okay, so yeah, I mean, it is definitely safer as compared to the prostaglandin. Okay, so because prostaglandin, they will have their own problems, the bronchospasm, this, that, already, such kind of patients, they're already having this problem. So definitely, mithazine can definitely save you. So we go ahead with the next case now, Dr. Rajalakshmi. Do we have Dr. Rajalakshmi?
Yes, ma'am.
Hello. Hello,
Hi,
Dr.
ma'am.
Hi. So we go ahead with the discussion. You have this 32-year-old para 1 previous 1 cesarean section patient. The first child is male child, only 1 year. And this lady conceives, and she comes to your city she comes to your clinic during 6 months of her pregnancy, just because her husband is transferred there. Okay. So she comes to your hospital with history of bleeding. By the time she comes to hospital, the bleeding stops. But when you inquire further, then she gives you history of spotting during early pregnancy once or twice, and that time the ultrasound was done and it was showing low-lying placenta. Now, because she has bled again, you do her ultrasound, you find that the placenta is low-lying. Okay, there is placenta previa, and this retroplacental sonolucent zone is missing. Okay, you have lots of RP legs there. So an anomaly scan is normal. This lady comes to you at 30 weeks again, and she starts bleeding profusely at your hospital. She collapses. Now, what is your diagnosis? How will you counsel the patient relatives, and what is your management? Dr. Lakshmi.
Yes, ma'am, seeing at the case scenario, she's a 32 years with previous 1 cesarean section, and she's having warning hemorrhages on and off since her early pregnancy. Even one of our ultrasound is showing that it is a case of placenta previa, but it was at 26 weeks of pregnancy. But now, because she has bled profusely at 30 weeks, and seeing the scenario, it is probably a case of, yes, placenta previa, but there is a possibility that it could be a case of placenta accreta spectrum also.
Right.
Because of the previous cesarean section, we have to keep that in mind first.
And your is also giving absent RP leg.
Yes, ma'am. In the ultrasound, that is given absent RP leg. Yes, other findings could also be there, like placental lacunae could have been there. Hypervascularity could have been there in the feeding vessels, breaching vessels. That loss of the zone is there. So that has to be seen in the ultrasound, but many times those are not seen. But still, because the history is previous cesarean section, possibility of placenta accreta spectrum is there, ma'am.
Right.
And coming to the management, ma'am.
Yes.
First of all,
collapse. We have to be hurried up now.
Ma'am. Yes, ma'am. Because she has bled profusely and she has collapsed.
Right.
Such cases should ideally be managed in a multi-specialty hospital, tertiary hospital. So first of all, as soon as she has collapsed, the call for help alarm has to be gone. We have to inform everybody, like the blood bank team, to initiate the massive transfusion protocol, the CCU team, the anesthesia team, the OT team, the NICU team. Now coming to the management, the resuscitation of this patient should work simultaneously along with emergency cesarean section which might land up into a case of emergency cesarean hysterectomy also. So those has to be kept in mind. So we will prepare everything for this patient.
Yeah, Dr. Rajalakshmi, up to this you have said it excellent. I would just ask you to elaborate few things. One is you have discussed the management very well, but what about the relatives? Have you
Yes, ma'am.
counseled them?
Yes, ma'am.
So how will you counsel them?
Ma'am, in this case, we
And
have to.
second point I want to clarify from him that when this is an emergency, basically you have to operate, that you have to explain to the patient's relatives. But whether it will be a cesarean section or a cesarean hysterectomy, should you not write in the consent before, that is whether, I mean, when you are taking a consent, it is emergency cesarean hysterectomy, the consent has to be there right from the beginning, or you want to take it afterwards?
No, ma'am. In this case, we have to tell the patient party that even though she is having only para 1 and this baby is premature, we are not knowing about the fetal heart rate also in this case. She is an emergency, very high risk case. Right from the beginning, the patient party should be counseled that there is very high possibility of landing up into emergency cesarean hysterectomy, and this has to be clearly mentioned into the file, because ma'am, we frequently see such cases, and if we don't counsel the patient right from the beginning, it becomes very difficult even for us also, because once we open the abdomen, there can be a massive bleeding. And the main surgeon may not be able to go and talk to the patient, so this consent should be there right from the beginning, ma'am.
That is one. And second point, what I'm trying to stress here is, if you have not explained them before, if you have not taken the informed written consent before starting the procedure, they will feel that you have done some blunder or something has gone wrong, and that is why now you have come to take the consent, right?
Yes, ma'am.
Anticipation, prediction, correct? Okay. So now you tell me whom all you want in your team. You want to operate this patient. It is an emergency. You have to take her up for cesarean section. You have arranged for blood and blood products. You have said initiate massive transfusion protocol. But who all do you want in your team now there?
Yes, ma'am. The senior anesthesia person should be there. Senior obstetrician should be there in this case.
Right.
And along with, we also inform the urologist in this case, because ma'am, there is high chances that it could turn out to be a case of placenta percreta, or the placenta might be going into some nearby structures. So the urologist team should also be informed, and at times the surgical team should also be informed regarding that we are going to take up this case in the OT and might need their help.
Who else, if at all you are working in a medical college, or maybe if you have the facility, anybody?
Interventional radiologist, if the facilities are available, that should also be intimated. They should be informed.
Correct. So you have to have the senior obstetrician, senior anesthetist, the neonatologist with NICU facilities, of course, the blood bank at your disposal. Whatever you need, we are there. So that is how. And of course, not only this, either the surgeon, oncosurgeon, or urosurgeon, either of these three, and then of course an intensivist in addition to the interventional radiologist. Intensivist, you need to have, sometimes you may even require the hematologist, but intensivist, if you available, definitely should be made available, right? Okay, so go ahead. Now you have talked about that this is your team. What anesthesia you want to give for this patient?
This patient will go ahead with general anesthesia.
We will not decide. Leave it to the anesthetist, right? We will not
decide. Most of the time, obviously.
Yes. You're right. You're right. This is our patient. You see what type of anesthesia. We just want everything should go smoothly, right? So that is how it is. Now, what are the precautions during surgery? What incision, abdominal incision you want to take? How should be your uterine incision? Please go ahead.
Yes, ma'am. Now, as we have prepared everything, everything is ready in hand with the blood and blood products available. We are taking up this case in the OT. Now, because we are suspecting she's a placenta previa with placenta accreta spectrum. So a midline vertical incision should be given. We are not going ahead with the phalansteal incision in this case, because we will be needing lots of exposure, and we might also have to go ahead with internal iliac artery ligation also. So a midline vertical incision will give, we will open the abdomen.
Yeah.
And then once we are inside, generally, ma'am, in such cases, we don't go ahead with the lower uterine segment incision. We go ahead with the transfundal incision because we try to minimize touching the placenta in such case. We immediately take out the baby.
I would like to you to give a message from this forum that it should be always a vertical classical cesarean incision.
Yes, ma'am. It should be a vertical classical cesarean incision. It should not be a lower uterine incision.
And in some cases, maybe even that is suspicious, that you find that, if you have mapped the placenta, you find it is coming quite higher. So
Yes,
maybe a transfundal incision, the transverse
Yes,
fundal
ma'am.
incision.
Yes,
Right.
ma'am. Transfundal incision is the most commonly which is being given, because many a times there are big vessels which are encroaching into the lower and even in the middle segment of the uterus.
Correct.
So it
Correct.
becomes difficult. So once we have given the transfundal incision, we take out the baby, clamp the cord, cut and hand it over to the neonatologist. And then we don't touch the uterus actually. We just close the uterine incision and we just wait. And in the meantime, we go ahead with the bilateral or unilateral, whatever possible, internal iliac artery ligation.
Okay. Should you close the uterus immediately? That is what my question is.
Ma'am, many a times if the patient is not, like she is bleeding, ma'am, so probably she'll be bleeding. But if the patient is not bleeding and we are not getting massive, means it is not pouring type of things, then we can wait, because kai bar, ma'am, the placenta might even detach and come out.
That is what I'm trying to tell you, that whether we should close the uterus. Otherwise, then from where you will remove the placenta?
Obviously, ma'am.
So only one precaution, what I want to tell you is that you said not to touch the uterus. No, not to touch the placenta.
Yes,
absolutely no attempt at separation of the placenta. That is one. But leave it to the nature for some time. By the time you just, clamp those edges of the uterus, what you have cut with green ammetas or some sort of forceps, which will, compress as a hemostatic forceps, correct? And of course, you go for meanwhile the stepwise devascularization, correct? Now, if you are lucky enough, maybe she has bled profusely. That means majority of the part of the placenta is separable, correct? If it was morbidly adherent, she may not have bled also.
Yes, ma'am.
Okay.
That's
So
the
that
main
is
thing.
patchy adherence, correct? Okay. So now that suppose majority of the placenta gets separated, then you may do the removal of the rest of it. Okay. But then you will leave it to the nature, and for some time you will get to know that things are separated and sorted out, and you are happy that nothing has gone wrong. But suppose if it is a placenta accreta spectrum genuinely, as you said, then of course you do stepwise devascularization, go for patchy resection. Now, what are the conservative surgical procedure for PAS?
Conservative surgical management, we can even go for, like, if it is a patchy placenta accreta type of case, then the wedge resection of that part can be done, ma'am.
Yes. So what is that called as? It is called as triple P procedure.
Triple P.
Yes.
Triple P.
So what is that?
Ma'am, I just don't.
Yeah. So
Ma'am, mapping
Yes.
the placental
Mapping,
edge, 1, then
Yes, Dr.
stepwise devascularization 2, and
Yes.
3 is you just take out the placenta which is separable and remove the wedge from the part which is not separable.
Yes, yes, you're
And then
right.
repair
You're
it.
right. Only I would help you in knowing what is the P. Where does this P comes? One is placental mapping. Second is stepwise pelvic devascularization. And third is patchy resection. That is how the 3 P's. Okay. Okay. So you have done wonders to this patient. Suppose this placenta is fully adherent. Even today there are few people, you will also get to see some of the videos, these patients, they are promoting lots of videos nowadays. There are many obstetricians who are actually going for the conservative surgical procedures nowadays as a routine. So one is triple P. Second is if at all you want to conserve the uterus, because this is for her, it is a second pregnancy. But suppose if it is a first pregnancy where the baby's survival is not assured, and you want to save this uterus, conserve this uterus, if she is not bleeding, you may go ahead with the conservative procedure where they do, what is called as Comog MG stitch. Yes, the lower, in addition to the stepwise pelvic devascularization, what they do is on both sides, the upper uterine arteries, anterior to posterior, posterior to anterior, they take a big bite of the, they tie the uterines on both sides. In addition to the stepwise devascularization, on both the angles of the incision, they take a very deep sutures and they occlude the things so that majority of the field becomes vascular. And then in addition to this, they take a what is called as cervico-ischemic stitch, that is called as Comog MG stitch. Okay, so all in all, they make the uterus absolutely like ischemic, and then they scale out the placenta and throw it out. That's all. So then, of course, you need compression sutures, this, that. But people are becoming aware of it. They're getting acquired to the skills of this, and they are getting succeeded also. So let us be hopeful that, optimistic that we also can do this procedure, such kind of procedure in future quite frequently. So this is how the diagnosis is. Now, this patient, what all things you have to monitor, because you are giving a massive transfusion protocol, this, that, you are doing all this internal iliac artery. Suppose you have placenta accreta percreta that is going involving the bladder also, there is no plane of separation, then how do you go ahead with it?
If it is a case of placenta accreta, percreta, like going into the bladder plane, so I think like we need the intraoperative assistance from urologist. It is always better to call the urologist team, and then we slowly and try to separate those parts, and whatever breaching vessels we find at that planes, we try to ligate those bleeding vessels.
Right.
And many a times, ma'am, because there are high chances, because in placenta percreta, that their bladder will be injured.
Right. So you have to have the urologist for your health right from the beginning. That is what I said. Maybe sometimes they, stent the ureters also at the beginning of the procedure. That can help guide you. You will not include those ureters in your clamp, because if it is percreta, there may be lots of adhesions, lots of vascularity also. Correct. So finally, friends, you have managed this patient also very well, and fortunately, maybe the baby is also fine, because we have prepared this baby setting that maybe Maxelf and steroids, everything. So this patient is managed well. But was this preventable? Was this mishap that happened? She suddenly bled and collapsed at 30 weeks. Could this have been prevented? Suppose once you diagnose the placenta previa, maybe at maybe 18 to 20 weeks or so, can the prophylactic cerclage have helped, or maybe the role of tocolysis? What is the role of tocolysis, UP?
Ma'am,
Yes, Dr. Archana?
Ma'am, in this case, there's no role of prophylactic os tightening, because prophylactic os tightening has its own indications.
Right.
And regarding the tocolysis, because she is a 30 weeks pregnancy
One more
right
thing
now.
I want to speak for this. Prophylactic cerclage, it has got specific recommendation, that is short cervix, 2.5 centimeter. That is unanimously accepted. But when you have placenta previa, if you try and take a stitch here, maybe sometimes she can bleed.
Torrential hemorrhage can occur.
Yes. So in fact, she will bleed that time itself and can create havoc. Correct? So that is one. What is the role of tocolytics?
Ma'am, even tocolysis has no role, and here the patient has already collapsed, so we have to take out the fetus. But if it was not bleeding,
we're not talking about now after the collapse, Dr. Priyanka. We are talking, was it preventable? That aspect, preventive aspect we are talking about, that when it was diagnosed as having placenta previa, was there a role of cerclage? No. Was there a role of tocolysis? No, because tocolysis means when the patient has contractions, then only you will
only then.
There's
Yes,
no
ma'am.
contractions,
Yes, ma'am.
right? Yeah.
Only contractions, with contractions.
What?
And if she was not bleeding, ma'am, then we could have given a Maxelf for the
That is what I am coming to you.
Yeah.
Yes, Darshana, what precautions we could have taken? You know, the patient came to you in maybe early pregnancy, she was somewhere, but at 6 months when she came to you, she was diagnosed at placenta previa accreta. Whether she was allowed to go home and do everything.
No,
What
ma'am. I will ask her
would have
to.
advised?
I will ask her to stay somewhere in the vicinity of the hospital and report with every event, even if it was a spotting, she should have been reported. I would ask her not to avoid any sexual intercourse. I would ask her not to take any, do any weightlifting, to go up and down the stairs. So, pelvic rest is advised to this patient. And then as soon as she becomes 28 to 30 weeks, I would have preferred to give her steroids and a Maxel regime, so as to because I think that this might land up in an preterm pregnancy.
Blood, at least few points of
And
blood should
yeah, I
have been
will
already.
counsel the patient that anytime you can go into a massive hemorrhage, so blood products have to be kept in hand before only arrangement of donors and blood should be done.
Correct. So, in spite of all this arrangement, Dr. Archana, whether we could have assured this lady a good outcome, or what, in other words,
No, ma'am.
what informed consent we should take from such patients?
Regarding the informed consent, ma'am, she should be counseled regarding the massive hemorrhage and the and she might land up in a hysterectomy. This should be counseled well in advance, and we cannot assure her of a good outcome any ways.
Yes, that is what I'm saying. Right from beginning, you have to tell her that, I mean, let whatever happen, how much ever we are prepared, we are not going to, we won't be able to prevent the catastrophe, correct? It is you that you have to take rest and avoid all these things. But in spite of, placenta previa bleeds when the patient is sleeping, okay? So in spite of all the precautions, things can go wrong, that is one. But as far as possible, you have to follow the precautions so that we can take this pregnancy at least little ahead till salvageability, correct?
Yes, sir.
Secondly, even when with so much of precautions and everything kept ready, we can't prevent the bleeding, which can be massive. And thirdly, they have to be informed that if at all it happens, we cannot assure you about the baby's prognosis, because it will all depend upon the gestational age at which it happens and the amount of blood loss she has had. So it is all, we will try our best to manage everything, but we cannot assure everything, because once a patient gets registered with you and she says that yes, things are like this, so we leave it to you. Patients tell you that, madam, we believe in you and we leave it to you. But when things go wrong, they will talk all rubbish. So that is how you have to tell them that we cannot assure you may whatever happen. We will only try our best to do best for you. That is all.
Every visit she should be counseled regarding the same.
Yes, and it has to be written informed consent, which has to be attached to our file and has to be there in our record also. Okay, that is how it is, because it's not only communication but documentation also. So our hard work, vigilance, our expertise, but the documentation and communication also plays a very important role. Correct? So we go ahead. So these are the green top guidelines saying that when you do a sonography at 16 weeks, at the earliest, even the 11 to 13 weeks sonography will tell you that it is the gestation sac is low lying or the chorionic plate is low lying, so that you can definitely guess it. But then 11 to 13 weeks, you can make out that maybe there is lack of the retroplacental sonolution zone. So whenever you are doing the anomaly scan, that is between 18 to 24 weeks, you have to look for the location of the placenta as well as the presence or absence of the retroplacental sonolution zone to confirm the placenta accreta spectrum. And of course, at that point, you have to measure the cervical length also, because that gives you a prediction that this patient may land up into preterm labor also. correct? So bleeding is one aspect, but if she becomes goes into preterm labor, the lower segment gets formed earlier, and she may start bleeding earlier. That is how you can predict that this is a patient who will bleed much earlier than what we think. So all these things we have all discussed. Management we have gone through. What precautions before surgery, during surgery, post-operative also we have all covered. And only one point I would ask you here, though we have all discussed here, for the diagnosis of placenta accreta spectrum, how do you compare ultrasonography and MRI?
Ma'am, regarding if it is done by a good experienced ultrasonologist, then we can very well diagnose it by ultrasound. But in obese patient and in those who are having a posterior placenta, MRI can be of more help in these cases.
Correct. So if you have a good resolution sonography machine and of course an expert sonologist, in fact the results are comparable only with the morbidly obese woman and posterior placenta, and also when you want to go ahead for the conservative surgical procedure, the depth of invasion of the placenta, the placental mapping, correct? So if it is not very deep, little superficial, so you can scrap it out. So that is what the management you can plan from this MRI. Okay, correct. So our aim should be, once you diagnose, you have to counsel, you give them precautions, you have to arrange everything. In spite of everything, you have to take a written informed consent. And then of course you have to tell them that our aim is to reach at least to 34 weeks, and how their cooperation is also needed for this. And then you have to prepare the fetus by giving steroids and magnesium sulfate. If at all this patient you could carry up to 34 weeks, you should make it a point to take her as elective procedure. And the reasons all of you know, that what you said, senior obstetrician, senior anesthetist, all these people will be available, and daytime, of course, everything will be easily accessible. So it should be a elective procedure and not an emergency, how it happened here. Okay, so I think we have discussed this. Only about coagulopathy, if somebody wants to speak, how should we give the massive blood transfusion? Yes.
The massive blood transfusion is, ma'am, the ratio of 1:1:1. That is one PRBC, one FFP, and one platelet are to be given. And sometimes cryoprecipitate may also be needed if the fibrinogen levels are too low. Then we have to keep the PTNR in less than 1.5.
Mm-hmm. Anybody wants to add anything? Any panelists?
Ma'am, 6 packed RBCs, 2 FFPs, cryoprecipitates.
Right.
6 platelets.
Yeah. So initially, whenever you are getting, alternately, so you just maintain the ratio of 1:1. I think that should be. And of course, you have to weigh the need and supply, and you have to keep the further pints ready. It shouldn't be, now things are getting ready. So it should be, the need and supply should be balanced, and the risk and benefits also should be balanced. And as per the fibrinogen levels and FTP, and of course your coagulation profile, you have to look for what component you want. So all these things have to be, known. So these are all the principles
And
of
we have to avoid circulatory overload also, ma'am, while giving a massive transfusion.
Yes, and now we come to what is called as, what is coagulation? Sorry, dilution coagulopathy. What is dilution coagulopathy?
And because all the platelets and coagulation factors are being used up while making the thrombus, and then fibrin is formed, then fibrinolysis is done. So because they are used up, and it's dilutional is because if you're giving a lot of fluids and all, then the coagulation factors get diluted.
Yes, but even when you are giving a massive transfusion protocol, the patient lands up into dilution coagulopathy.
Yeah.
So frequently you have to go for the coagulation profile. Okay. So this is what I have tried to sum up here, Dr. Pallavi. This is how many, what component contains what. So all of you know this. So this is a theoretical aspect. Should we go ahead with this last case now? Right?
Yes,
Should we
ma'am.
go ahead with the last case? This is a very, quick case. I will take it as Gravida 4, para 1 and 3 abortions. Now, last childbirth 7 years back, normal vaginal delivery, uneventful antenatal record, and normal ultrasound for, fetal growth and placenta. Everything is normal. I think not this. I think I will take, this is a simple case, the uterine inversion. I will take one case only, which will be, very, very good message, a simple but very important message. So a grand multipara admitted to emergency. She came to you with obstructed labor. Actually, this lady has had previous one normal vaginal delivery, and this time she landed up into obstructed labor. Blood pressure is 130/80, maternal exhaustion, and like a thickly meconium state. She was given fluid resuscitation, antibiotic prophylaxis. She was taken for cesarean section. 4 kg baby, distressed baby was delivered. And because it was a large baby, there was little extension of the incision, not into the broad ligament, not into the uterines. And, it was very simple. It was correct, sutured properly. There was no intraoperative blood loss, and the patient was stable. After maybe 1 to 1.5 hours, after shifting into the ward, suddenly her pulse rate become, her pulse become steady. She started sweating, little confused look, drowsy, she started vomiting. So on examination, when you examine her, there was no para. The abdomen was soft, absolutely no guarding distension. There was no bleeding absolutely from outside. Okay, no evident signs of either internal or external hemorrhage. Uterus was very well contracted, but she was collapsed. What is your diagnosis? You feel clinically, Dr. Archana?
No, in this case, ma'am, actually all the obstetric and non-obstetric causes of postpartum collapse are coming to my mind.
Yes.
And
I'm
as
sure
you have ruled,
excluded the hemorrhagic.
and you have ruled out the hemorrhagic causes of obstetric hemorrhagic causes.
Right.
So in this case, I would quickly look into the local systemic and general systemic examination has to be done. So ruling out all the hemorrhage,
Provided you.
I will.
That they have provided us, Dr. Archana.
Yes, ma'am.
That they have
Yes, ma'am.
provided. Her pulse rate and her
So-
pulse is steady. Her looks
Yes,
is confused, drowsy, vomiting, and abdomen
So
is.
while I do this, ma'am, I'll ask my staff to take a saturation of this patient and a blood sugar of this patient.
Right.
And I will look for JVP, and for the systemic examination, I will look for Krebs and.
Okay, you still have two
Yes, ma'am.
differential diagnoses I can make out. So one is
Yes, ma'am. I'm thinking about heart causes also. I'm thinking about embolism also. At the same time, I'm thinking about hypoglycemia also in this case.
Okay. Any role for aggressive fluid therapy?
Not, ma'am, exactly. We have to definitely give fluid because the
She's
blood
already
pressure is coming
receiving
down.
She's operated for cesarean section. She's on IV fluids. So no need for additional aggressive fluid, correct?
But vasopressor should be given
Yes,
to.
that's required. Yes,
Yes, ma'am.
because you are suspecting pulmonary edema.
Not exactly, ma'am, pulmonary edema, but I'm thinking about embolism.
Okay.
And
Okay.
which might be an amniotic embolism or a pulmonary embolism, and then
Correct.
it might be a postpartum cardiomyopathy,
Correct.
peripartum cardiomyopathy, or it might be something else which we have to rule out.
Good. But whether you would like to give her, because what history I have given here, she was given aggressive fluid resuscitation when she came because she was little dehydrated. Okay, right? So because of the obstructed labor, she was dehydrated. She has received antibiotic also. Okay, so
But ma'am,
aggressive
because she's in obstructed labor, so we have to resuscitate her with fluid because she is already dehydrated.
that we have done already. That is what I'm saying. That we have done. That is what I wanted to show you, that we have done her at admission, and fluid wise now she's stable. That is what we feel. Okay. Now you're right. So here we put query, aggressive fluid query. We'll think over it. Vasopressors, you are perfect. Yes, bang on. You have to give blood component.
We'll hold, ma'am, because there's no hemorrhage right now.
Yes. Even her hemoglobin looks like good and there's no pallor. I mean, there's no internal or external bleeding sign. But yes, okay, you will say, okay, keep one ready at least. Any bedside investigations?
My
Now,
first bedside investigation will be, ma'am, whether what is the saturation of oxygen and what is the blood sugar level.
correct. Okay.
So after
Any help or any transfer in this situation? No.
Ma'am, first I'll rule out the cause.
Yes, unless you at least manage this patient initially, you will not. Unless you stabilize her, you will not shift her, at least the initial part. Look at the bedside investigation. Hemoglobin 10.8. Sugar levels very high, that was nearly 600. Urine sugar 3 plus, ketones 2 plus. Now tell me your diagnosis.
She's a case of diabetic ketoacidosis, ma'am. So the sugar levels were not
It's a
done
learning
in
lesson
the
for all of us, correct? You know, your antenna should be that sensitive, because you know all of us are doing these patients day in and day out, and we are always worried about our bleeding and bleeding, whether internal or external, whether
Yes.
we have done something wrong.
Very
Correct?
true.
Definitely, we have to keep suspicion to us only. Definitely, we have to take precautions, but always think of this also. It will just take few seconds of your time. You know, urine sugar.
I was thinking more towards hypoglycemia rather than hyperglycemia.
Right. That also is true. But this is a real case which happened in the city of Ahmedabad, and this obstetrician was fined around I think 1.5 CR. This case is also discussed by some of our medical legal consultant, and of course, it is, you know, the obstetrician has lost this case in the highest court, and 1.5 to 2.5 CR. I think they have to pay, and the reason being, now I just quickly run through. I will not tell you what the management. All of you know the management of this patient. You will do now the fluid resuscitation. You will add insulin as per the sugar level. You will call your physician friend. I'm sure you have lots of friends. They will help you. Okay, that is not at all a question. The question here is whether this was preventable. For every case, I'm asking you this.
75 gram OGTT should have been done during the.
Correct.
For a
So that
patient,
is what
we should
I'm
have-
trying to tell you, that, you know, this court, see this picture. Court expects us, or the law expects us, to know the minimum standard of care, minimum clinical acumen, what our fellow obstetrician or our fellow colleagues have. Correct? So missing this diagnosis is a crime. Okay, because our own parent organization, Foxy GCPR, Foxy ICOG, and of course NHM and Government of India, Minister of Health and Family Welfare, NHM and DIPSI, all of them recommend universal screening for diabetes in pregnancy, meaning screening of every woman during every pregnancy. Not that first pregnancy I did not have diabetes, so I will not have. No, every woman during every pregnancy, and single step 75 gram OGTT. If they have done this, they could have monitored this patient throughout pregnancy, and our patient would not have landed up into this complication. That is a simple message. Now, just to conclude, I would say that every obstetric unit and every person of the obstetric team must be trained and skilled to manage maternal collapse. You cannot shift this patient in this condition. There is no time for immediate referral, and referral in unsettled case may worsen the situation due to multiple issues, and you are liable for negligence. It's a crime to shift the patient in unsettled condition. So the team should manage effectively then and there only, and then only after stabilization you should shift this patient to that particular obstetric HDU or ICU. But not only the multidisciplinary team you have, and it's not necessary for every obstetric or small nursing homes to have a I mean, it is not possible to have a multidisciplinary team and HDU. That means it doesn't mean that every patient we need to shift to ICU and HDU. You have to know the basic standards of care. You have to screen every patient properly. If at all something goes wrong, you have to manage it then and then only, so as to avoid your patient getting transferred to HDU and ICU. So that is what is the message. So I would like to thank all of you, and of course, just a humble appeal to all of you for supporting my candidature, and of course, vote for me in large numbers. Please do make me as your first choice, though West Zone has two votes, two candidates from West Zone. Please make me as your first choice. Thank you so much once again.
Ma'am, you are the most popular candidate this time.
Thank you, my dear. Thank you so much. And
Uh,
I'd like to thank Dr. Meenu, the president of Dehradun, Dr. Archana Singh, the secretary of Uttarakhand, I would say, and of course, Sarveshwari, Madam Jyoti Sharma, all my panelists, Dr. Archana, Dr. Priyanka, Dr. Swati, and of course, Dr. Pallavi. I thank all of you for being such wonderful panelists with up-to-date knowledge. I'm very happy, I have enjoyed the discussion with you. So thank you so
I
much.
just want to add one thing. I just want to say only two things. One, the panel was real academic feast.
Very interesting. Very
The
interesting.
excellent moderator with very knowledgeable panelists. So I will like Anudi to say something about this panel. Dr. Anu ma'am.
Yeah, I just want to say the panel was very interesting and take home message. I would say that each
In fact,
obstetrician.
I was about to invite both the experts, madam. So please do comment and do add your expert comments to this.
That's why.
Thank you so
Yeah.
much.
So I think every obstetrician should have in their mind previous pehle se hi that these are the cases, this sort of thing should be, we should be mentally prepared. PPH, eclampsia, inversion, uterus, sometimes you land up in something and your team should be ready. You should know whom to inform. Your leadership is very, very important. And Dr. Sneha, of course, the cases she has chosen were very good. And we are going to support her. Definitely Uttarakhand should support her as the future.
I don't think Dr. Sethi is there.
Very wonderful panel, Dr. Sneha. It was very enlightening and very, very well learning, very well. We learned a lot and all the panelists were very well knowledgeable, very knowledgeable.
Very good.
And they gave very important points.
I can see Dr. Sethi there. I can see
Yeah,
Dr.
yeah.
Sethi there, another
madam.
expert. Dr. Sethi.
I am enjoying the panel, really learned so much. Even at this age, I've really learned what cases, what take-home messages. I cannot, I don't have words for Dr. Sneha and the panelists. And I wish her all the best. And I'm sure you will win, Dr. Sneha. We are all with you.
Thank you, madam. Thank you so much for your blessing.
So without this panel, I don't think anything would have been completed.
Yeah. So,
and a real salute to Dr. Anu Didi because she worked with efforts for
Let me
years.
see whether
together.
Dr. Parikshit has joined or Radhika, have you called Dr. Parikshit? I don't know. Dr. Radhika?
Radhika, I think
is not there. I can
go for emergency. So Dr. Parikshit is there. He has joined.
Has joined? No. Let me
I can't
just
see
give him
him.
a call. Yeah. Let me just give him a call.
He was busy in emergency, so it's difficult to leave. And Radhika already had an emergency with her, so she handed over her charge to me.
Parikshit is here.
Hello, Dr. Jyoti.
Hello.
Welcome.
Radhika has left. She had an emergency.
Welcome.
Actually, yeah.
No,
Dr.
I've been through the whole panel, and
Yeah.
believe me, it was excellent. It was as if we were back into our resident days, and every aspect of each case was covered so beautifully, particularly in this medico-legal times when you are, and nothing is forgiven, nothing is taken. A doctor is not going to be left for even the slightest of mistakes, and especially the diabetic case in the end. that was, that was really a case, I think, which should every obstetrician should know. Every obstetrician should know, because this is something, unpardonable, really.
A lesson for all of us.
Yes.
Thank you, Jyoti. Your words are really golden words for the panelists.
Yes.
I think this panel was excellent. Excellent, Shirley.
Dr. Parikshit had joined? No?
Actually, he has written me a message that, Madam, I have just finished. But then, if somebody can call him, I have just given him a ring. But I think it will be good if.
I think.
Radhika, is she there around?
Radhika has just had to rush for an emergency, and I think she's handed over her proceedings with Dr. Sarveshwari.
But then how to now?
Sarveshwari, do you have any way of calling Dr. Parikshit?
Calling Dr. Parikshit. Let us see if he picks
If
up.
he says he's coming, he's joining, then we'll continue. Otherwise, I think we are giving best to
Because
Sneha.
I have requested him personally, and he is the best speaker. I would tell you, he's the best speaker.
He's my favorite speaker.
And
Jyoti is my favorite in all these things.
Dr. Parikshit is not picking up. I think he is busy in some emergency. So we had a wonderful panel and wonderful talk. Even Dr. Geeta gave very good talk, and even the panel was excellent panel. We all learned a lot.
Enjoyed.
And again, all the best, Dr. Sneha, for your endeavor. And we all are with you. Hello?
Whole Uttarakhand is with you. Don't worry.
Definitely.
Thank you.
If Jyoti says it will be done, so
it is already done. Already done.
Ma'am, Jyoti is a very spiritual person, and what
I know.
Really,
And I'm really proud of her.
All things apart. All things apart, this particular, in the changing scenario of obstetrics now, with women having children with such difficulty, childbirth, which was so natural to a woman.
Parikshit is writing some message.
Oh,
to
lovely. So with the changing scenario, I mean, where childbirth has become a challenge to women. You see, it used to be.
I agree. I totally agree with you. Archana, your answers were very good.
Thank you.
Dr. Parikshit, you have to just listen to him. He speaks very well on.
I think we
very
can
good videos.
We can next time we will hear him.
Yeah. Let me see what is.
He's a very good speaker. I know. I have attended his many lectures. So it's.
Dr. Minu, you did call him, no?
I called him. He didn't pick up. He didn't pick up. So must be busy in some emergency.
Just send a message to him.
Yeah, he was writing some message to me, and then I don't know whether. Not able to.
Anyway, we had a wonderful session. Next time we'll keep Dr. Parikshit talk and let us have knowledge about the forceps part. And
Once let me just convey him that we will close. Let me just convey. He has messaged me. Sorry, I tried joining, but could not. This hospital Wi-Fi is weak. That means it is late also. So that is why he has taken. We will now have him as first speaker next time. Okay.
Next time, yeah.
With your permission, we will definitely have him as.
Definitely, Jyoti and Minu, both of you. Next time,
Definitely,
Sure.
definitely.
Good
Thank
to
you
see
so much.
Dr.
You know,
Jyoti.
I'm so happy that, you know, these such good speakers, they are just at one phone call, they are ready
I
to
know. I
associate.
really love his lectures.
Yes, he's always there in my program. So, you know, Jaideep is taking care of Oxy and other things, but then Parikshit is a very, very good speaker, and he has all those videos, you know, actual demonstration videos, skull, pelvis, this, that, for lots of learning. So it's a very good, in fact, missed it, but takes time, definitely. Thank you so much.
He's always in the conferences. I've seen him. I have listened to him, and just Sneha, you can give a lovely message to him, and our best wishes are with you for whole of the country. May the blessings from Devbhoomi Uttarakhand goes to Kanyakumari, up to Kanyakumari.
Thank you,
Yes,
madam.
yes.
That
Dr.
is what is
Sneha,
good. Yes,
Dr.
madam.
Sneha, there's one thing which I wanted to just ask.
Uh-huh.
How safe is it to give a abortion pill in a woman of a previous cesarean?
Correct.
How
In fact, uterine scar is a contraindication to empty pills. That is a statement right from the beginning. But nowadays, you know, people are using it day in and day out. So definitely, people are not following whatever conventions we have set up, whatever rules and regulations we have set up. So that's a very reason this patient landed up into complications. That's what we said. It can be even scar ectopic. It can be even scar rupture sometimes. Yes.
Scar.
Yes.
Yeah. So this is what you are very correct. In fact, it's a strict no to give.
It would be better after ruling out an ectopic. It would be better to do an evacuation than land up in another preventable thing.
Correct. You're right. That is what messages we are trying to give. But people are, you know, there are two different schools of thought. There are some aggressive people. They say even for second trimester abortion, you can use meso. You know, that is why.
That is, you know, I mean, this is where how things start getting wrong.
Let me by Foxy. You know, all these points we have to note it down, and we have to forward this to the MTP committee also. So I'm sure I'm going to do this for the MTP and Family Welfare Committee. I'm going to forward your message. Okay.
Thank you so much. Thank you
so much. Thank you.
And once again, all the best. And already we congratulate you.
Thank you, madam. Blessings and best wishes. In fact, that is very much needed. All of you know what everybody is talking, that Sneha should have been the top scorer last time also. So some things go wrong sometimes, but we have to go ahead.
I'm sure things go wrong for the good.